As president of SOM, I'd very much like to welcome you as part of an international audience to today's Long COVID Summit. There are two hashtag links, hashtag Long COVID Summit and hashtag Long COVID and Work. The second link will endure beyond the event, so future posts might link people back to posts made at this summit. So this summit is the brainchild of Professor Ewan Macdonald, and it's my pleasure to hand over to Ewan, who will provide the context of the event and introduce our first speaker. So Ewan, over to you.
Thank you very much, Anne. It's a pleasure to introduce this meeting. I chair the Long COVID stakeholder group of the Society of Occupational Medicine, which is multidisciplinary and from across the UK. That group's been meeting for some time, and this meeting is a accumulation of a lot of our discussions, and it's essentially the need to take stock. The first challenge of coronavirus 19 has been to cope with a tsunami of very sick people. But the developing aftermath is just as impactful because of the number of survivors with long-term effects. I first became aware of what is now called long COVID when visiting a friend socially in December 2019. He'd caught a bad cold, which apparently had got into his chest, and he was complaining of very limited exercise tolerance. I kept my distance. Dave had been a mixed martial arts exponent and prided him on his strength and resilience, considered himself an Iron Man, and refused to go to his GP. Fortunately, he recovered, but found that he had a large reduction in his exercise tolerance as measured by how far and how fast he could walk his dogs. He was also having odd chest pains. And so I eventually persuaded him to see his GP, and he was referred from his GP to a hospital physician. You will all guess the outcome. He was diagnosed with lung scarring and a recent myocardial infarction. This is a relatively young man. He estimates his exercise tolerance as now being about 40% of that prior to his illness, which has affected how much he personally can do in his very successful boat trailer and boat transport business. And then sometime later, I've seen many cases of long COVID clinically as an occupational physician, but sometime later, I saw a mature social care worker who was referred to my clinic by our employer, previously physically very fit, really liked outdoor activities, doing wild camping with our family. She had caught COVID, been admitted to hospital, been in ICU for 3 weeks, and 2 weeks inpatient rehab, and very much rehabilitation prior to being referred to me quite late in the process. Very highly motivated to recover and traumatized psychologically by her disability. She had sustained a vocal cord hemiparalysis, lung damage, physical weakness, now walk about 400 meters with a stick, has to stop frequently when doing that, and 6 months later was still unfit for her job. So these and many other cases have arisen post-COVID, and the focus, of course, in a pandemic, this hopefully unique experience we'll all have of a pandemic, has been in the acute treatment, acute care, keeping people alive, and as well as the prevention aspects, controlling the pandemic through vaccination and the other steps. The issue with long COVID, most people suffering from it are of working age, and the number of people being referred to occupational health for advice about fitness for work has steadily increased. And that is the stage that many of them have now reached. everyone's concerned to get back to their normal functioning, their normal reality. And it's been quite hard for them to take. We've learned all the time, we're learning it's a multi-system disease. It's not just a bit of flu and a bit of fatigue after it. It's very much a multi-system disease, which was poorly understood initially. And it's affecting at least 10% of survivors, but probably many more have illness, have prolonged symptoms. There's a huge impact on work. And for many, it will affect their roles. For example, if they're undertaking safety critical work, if they have the very common brain fog. So potentially we have in the UK about 1 million people affected by post-COVID, long-term post-COVID symptoms. If we take 10% of all cases, mortality being around about 0.5 to 1%, and we've had 12 million cases or so. So it's potentially a problem of 1 million people of working age. So in the world of occupational health, we are very used to seeing workers with multiple health problems being referred to us by their employers, and having to try and provide some what I call late onset rehabilitation through work adjustment, phased return to works, etc., and accessing employer provided physiotherapy and mental health support where that is in place. Sadly, NHS rehabilitation facilities have not been up to the task at all, as clinical care in the NHS, like all modern medical care systems, has been based along single system lines. At least I'm talking about the secondary care system. So if you have a chest problem, you get respiratory rehab. If you get a cardiac issue, you get cardiac rehab. If it's an MSK, you get MSK rehab. And there's long waiting lists for most of these generally prior to the pandemic. Long COVID demands from all of us a different approach. Before COVID, the UK has had more people fall out. Before COVID, the UK has had more people fall out of work and with long-term disability than the rest of the OECD, because possibly because the NHS system has never been able to provide long-term multidisciplinary biopsychosocial case management, which I'm sure other speakers will speak about. And not at least since the closure of workers' rehabilitation centres in the 1970s and 80s. Now, worklessness leads to people dying early. Worklessness kills. We have to help people get back to function and work. The NHS is good at treatment, but poor at returning patients to their maximum possible function, including work. But that's starting to be addressed, and we'll hear about some excellent developments in NHS England have been working at the hardest at this. But across the UK, services are still very patchy. A further problem is that only 50% of the UK workforce has access to occupational health, which is a figure lower than all other developed nations. This further multiplies the large numbers who will become workless over the age of 50 if they're not getting no advice at the in the occupational setting. So long COVID is bringing these occupational aspects into stark relief. And the issues are massive, not only for the population that's at risk of prolonged symptoms, but also for the society and the economy. So having fought the battle of acute long COVID, I know it's not over, but we're starting to win. We now need to do everything in our power and utilize all our resources, in my opinion, to minimize the long-term consequences of this complex and multi-system condition. Today's program has been developed to take stock of where we are with this chronic condition, share patient experiences and clinical knowledge, and inform the future developments in our battle against this new cause of disability. And I'm really very grateful to our fantastic range of speakers and to Nick at SOM for making this happen, and also to Anne Harris for supporting this webinar. So I think I've done quite well in my timing, which is good because we really want to hear from everybody else. So I'd like to hand over now to Dr. Nisreen Alwan, who's an Associate Professor of Public Health in the University of Southampton. So Nisreen, thank you for agreeing to speak. Over to you talking about the epidemiology.
Hello, can you hear me? Sorry. Can you hear me?
Perfect. Perfect.
Can you see the slides?
Yes, that's great. Thank you very much, Nisreen.
Thank you so much, Ewan. Thank you for inviting me to speak. It's great to be here. So I'm just going to introduce, I suppose, the massive problem that we have, that is long COVID. And I'm just going to take you back in time when this started just over a year ago, first wave of the pandemic in the UK, and the narrative that everybody was talking about was a black and white narrative. So you were either in a minority of people who would be high risk of getting severe disease and essentially dying from the infection, but the majority of the population, it was fine. It was just, you could get the worst case scenario, you could get a bit of a flu-like illness and you'll get better within a few days. We obviously now know that we've got this big gray area in the middle where people are, are ill for a long time, which is long COVID. It is disappointing that the narrative that we hear still in the policy still confuses survival and recovery, and it is really focused a lot on the acute end of the hospital admissions and the mortality, and that's still what shapes policy, pandemic policy, even in the second year. So why am I here? I'm here because I'm one of these first waivers who got COVID symptoms back in March, and then not really fully recovered, even though thinking I recovered several times, but these symptoms I experienced, some of them keep hitting back, and a couple of new ones as well. And that's been my journey throughout the last year. What I had is, the positive thing in the spring was the accounts of other people having similar experiences, people not getting better after several weeks, even though they're not in the declared risk factors for severe disease. People sharing those experiences, social media were really a lifesaver, because it was at a time where there was absolutely nothing known about this. But come the summer, I started really putting my public health epidemiology hat on. I was really astonished that none of this was being counted, measured in any sort of way. Our bread and butter epidemiology of measuring not only mortality but morbidity was not really being done. There were no morbidity measurements taking place. So I started writing about it, saying, we need to measure this, we need to quantify it, and we need to know what recovery looks like from, the millions which were getting COVID, not necessarily going to hospital, but having it at home and then not fully recovering. There was a first BMJ webinar on long COVID, trying to figure out what it is, in September. So what is long COVID? Long COVID is still an umbrella term. It's a patient-made term, and it really does reflect those early experiences where the patient were the experts in terms of their lived experiences. So I would define it still as not recovering from COVID-19 symptoms for several weeks or months. There are different cutoffs in terms of what the guidelines say. And important to say that it does happen, even the so-called mild infection. It can be very debilitating, and fatigue seems to predominate the narrative, and it's certainly very pronounced in people with long COVID. But to break it down in terms of what it means, we need to go a bit deeper. So how common is it? It's been a big thing to a bit controversial, really, in terms of the prevalence of long COVID, because we were not measuring it. So there are variable estimates. We do know now that people who were admitted to the hospital, so mostly severe cases, particularly in this country, have a very common non-recovery rate, even months after. There's some concerning studies looking at very much higher risk of death few months after discharge from hospital, and readmission with higher rates of heart disease, kidney disease, liver, diabetes. In terms of the mild moderate disease, it's been less studied, but the range is quite wide between 1 in 10 to 1 in 2 people having symptoms after a few weeks or a few months. There's even less data in children. There are some preliminary estimates from the ONS in terms of continuation of symptoms for a few weeks, as you can see. And why do we have this? Well, we have this because surveillance is not measuring morbidity as surveillance is measuring mortality and admission to hospitals. So we have to depend on research studies. Most of them are quite small, and they vary in terms of how they assess, the case definition, the whether people included had the lab confirmation, which again is linked to policy and access testing, and how representative these studies are. But also very difficult in terms of the nature of the disease, because as I mentioned, even my personal experience and many others, it's got this relapsing nature, this illness. So you kind of think you're almost there and you're completely recovered, and it hits you back. So when do you draw the line? I won't go too much into the potential mechanisms because probably they might be discussed later, but we still don't know is the short answer. There are theories about it being some sort of autoimmune disease, a result of scarring, fibrosis, inflammation. Even we can't exclude persistent virus because it's been shown in biopsies after several months of infection studies. So we still don't know, and it might be all of these things, some of these things, or only one thing. We don't know. So we really wanted to capture the experiences of people with long COVID, particularly for those from the survey from the first wave. So we did a survey, which was we recruited through social media. The survey was completely co-produced with people with long COVID. So not only me, other people from the long COVID support group as well. And what we found is basically we had in the sample, we had just over a quarter who said they had a lab confirmation of the illness, whether it was PCR or antibody. And you can see some of the figures we got here, and the ones between brackets on the slides are, we did everything. We compared the lab confirmed with the non-lab confirmed, because that's what comes up all the time is, well, how do you know it's COVID? For a lot of people describing that they've got long COVID. And really there were, striking similarities in terms of the proportion, as you can see. But these people were mainly of good to excellent health before the infection. And the pattern, as I said, was mainly fluctuating, relapsing, comes and goes. And you can see from here what the main symptoms that people were reporting were. So, you had the fatigue, or we called it exhaustion, because we wanted to really define exactly what we mean by the questions. There was a collection of cognitive dysfunction systems, so poor memory, poor concentration, what people term as brain fog, and confusion, and these worryingly seem to develop, become a bit more common later in the illness rather than the initial symptoms, because we assess the initial symptoms and then the ongoing symptoms. And you can see the main difference between those who are lab confirmed or not was the loss of taste and smell. And there could be several hypotheses around it in terms of, who is more likely to be positive if they've, got a loss of sense of taste or smell, or who tests, or who actually tests for the virus. The effect is astounding. I mean, so we found that at 6 weeks, people, about a third of them said they couldn't live alone. 50% of people at the time of completion, which was an average of 7 months, said their being ill affected their ability to care for themselves, but also to do all of these other things, which is work, doing domestic chores, caring for children, caring for other people, and definitely affected their mental health for the majority of them. And then a third of sample, or the participants, they said they had loss of income specifically due to this illness, and huge implications in terms of time taken off sick of work. And this is very quickly just to tell you, we clustered the symptoms. There were 2 main clusters, and you can see here where there's the bigger sample size. So the majority of the participants started with mainly chest symptoms and the exhaustion, and then most of the symptoms seem to slightly improve with time. So the acute is the bottom, and the ongoing cluster is the top. But then there is this spike in the cognitive dysfunction symptoms. However, worryingly, there was a minority cluster of people who actually started with more symptoms. So they were more multi-system. Most people were multi-system anyway, so about 83% had 3 or more systems involvement. But this minority cluster had more multi-system involvement, and they didn't really seem to get better over time, and some of them getting worse in terms of, you know, the symptoms they were experiencing. So it's an umbrella term. Are they different group within long COVID? I suspect there'll be more discussion about that, but we don't know. And obviously these different groups and debates about what long COVID is, how similar it is to other existing conditions, which really haven't received the attention and the research they need in terms of ME, CFS, you know, post-viral syndrome. It continues, but we don't exactly know how the spread of people with long COVID is across these different categories. So in terms of what are the priorities, the All Parliamentary Group on coronavirus had really 3 priorities or demands, which I really agree with, and they're sensible, good headlines, and that was debated in the first debate in Parliament on the 14th of January. And these are reporting, recognition, and research. So reporting is something I'm particularly passionate about, and that's what I've been calling for from the start. So we started this, you know, social media campaign called Count Long COVID. It's important to count long COVID, not only in research, but also in surveillance. So we should follow up people and just ask them if they've recovered or not. And that could be done using test and trace infrastructure. But also we need to establish disease patient registries, whether they're from primary care, long COVID clinics. So we can estimate the size. Well, we can know the size of the problem. But the important thing with this is to have really universal and inclusive diagnostic criteria and case definitions, which we don't have at the moment because we're still learning very fast about this. And also we need proper coding in electronic health systems, which is again not universal or standardized. In terms of the recognition, that really spans everything in terms of, you know, counting on long COVID as an occupational illness, because more people, some occupations put people at risk in terms of exposure to the virus, but it includes the adequate clinical assessment and, very importantly, the investigations to detect any treatable pathologies and treatment. And obviously, very importantly and relevant here is the rehabilitation as well. So we need equitable pathways to do it. And obviously recognition means policy, recognizing it. And I'm just putting an example where WHO is starting really to lead on this. And we had a report out recently, you know, which was a policy brief by WHO Europe on long COVID. We know we've got the NICE guidelines, and these are the definitions from the NICE guidelines. So the great thing about the NICE sign RCGP guidelines is that they came and said, you shouldn't discriminate based on whether people had a positive test or not. That's really, really important for patients. So I really think that's great. However, in terms of definitions, there are some timelines here, which is, you know, 4 weeks and then 12 weeks for the post-COVID syndrome definition. And that needs a bit more refining because that is still subject to wide clinical variations in terms of who gets that diagnosis and who doesn't, because it's not specified what qualifies. And the other thing which really we need to think about more is the bit about it not being explained by an alternative diagnosis. So if you have long COVID symptoms and then you get diagnosed with some organ pathology as part of investigations of your symptoms, then do you move out from the pool of long COVID and you move out into an alternative diagnosis? That could be a good thing for the patient because now they're more acknowledged, they've got that solid evidence of having something wrong in terms of getting the treatment and the support they need. But also that might leave people with the unexplained symptoms in the pool of long COVID. And that basically because maybe they've not had the appropriate investigations, and that might have be implications in terms of the recognition of people with long COVID. There'll be, I think, discussion on research later. Obviously, money's going into this, which is great. There've been a first call in the UK, which funded 4 studies of £18 million. There's a further £20 million call just announced. And then there's a 1.15 billion NIH call to fund long COVID studies over 4 years. Really essential not to exclude people with disadvantaged demographic groups, ethnic minorities, which are typically excluded from research, and if the research is based on the access to services like clinical services, they would be not really properly represented. So that needs to be addressed, and really important not to exclude the first wave, as they're the people with the longest experience of long COVID, even if most were not tested if hospitalized. So prevention of long COVID is basically these 3 steps. You don't get COVID in the first place. So pandemic policy is very, very relevant to preventing long COVID in terms of the infection matters. It's not just hospital admissions and deaths. What can we do to prevent progression from the acute to COVID to long COVID? And we need urgent research on that. In our study, there was some indication in terms of correlation. Obviously, it was a cross-sectional study, but there was some correlation of the patient perceiving they've had adequate rest or not in the first 2 weeks of the illness. And it seems people who thought they didn't were more likely to end up in that more severe cluster of symptoms, which was also associated with higher functional disability. And then the tertiary prevention is prevent complications, disability, and improve quality of life. Long COVID, like COVID, is not an equalizer. It increases inequalities between, in terms of the socioeconomic and ethnic inequalities. People who are more exposed to COVID are more likely to get it, less likely to get time off sick, so less likely to get that rest at the start, but also more likely maybe to lose income and possibly financial ruin as a result of getting long COVID. I want to end really with talking about how amazing it's been to see the patient movement with long COVID. I think it's a new era, really. I mean, I'm in research, and for years, we know about, we need to involve, we've been hearing about, need to involve patient research, do the public involvement, but actually seeing it in action, long COVID, it's amazing. The long COVID is going to change all of that, because the patients are the experts. They led the change. And we're here now talking about it in the conference because of these patient movements. So it's really important for them to be involved in every step of the way in all of these reporting, recognition, and research. And it's really also important, I believe, that we've argued that the name long COVID should really be widely acknowledged and stays really until we understand more about the mechanisms underlying long COVID, and whether it's more than one condition, because it's a patient-made term and everybody knows what it means now. So thank you so much. I'll end here and stop sharing my slides.
Thank you very much. Your timing was absolutely perfect. That was a really interesting presentation, highlighting the overview of the size of the long COVID problem and the implications for public health. I particularly like and agree with your emphasis on the involvement of patients, because they're the ones that have experienced it, and they can really add to the discussion and to our understanding of the condition, so that we can help and support others. So thank you. Our next speakers will now go on to answer the question, what is long COVID? Our speakers include Dr. Clare Rayner, who's going to provide some clinical perspectives, Lesley MacNevin, who's a specialist HR professional, who's going to explore some of the employment issues, Dr. David Strain, who's representing the BMA, and David Petrino, who's head of rehabilitation, joining us from Mount Sinai Hospital in the United States, and he's going to provide a US perspective. So over to our next speakers. Thank you.
Thank you, Anne, and thank you, Nisreen, I agree with everything you've said. It's uncanny we didn't, speak to each other at all, but you'll see that the sort of things I'm going to say will back up what you've said. And thank you to Som for having the awareness and the insight to bring us all together. I'll share my slides in a minute, but I just wanted to say a few things first. How am I qualified to speak to you about what long COVID is? Well, I'm an occupational physician by training, and we are trained to observe patterns of illness in populations. We're trained to be on the alert for new and strange things. I myself started with COVID infection a year ago and suffered from prolonged symptoms after that, really until now. And because of that, I've walked the same path with many other people with long COVID. In particular, I'm in a group of doctors. There are now 1,000 of us, many of whom have had long COVID for this period of time. And I've also been walking along with the other patient groups. So I've been in a position to see the patterns, and I don't think that some of the patterns have been made quite aware to people or in the publications. I had a friend from medical school and we got the infection exactly the same time, so we paralleled each other. And she described the symptoms as a collection of bizarre symptoms which were remarkably similar between people. What is long COVID? Long COVID is your 32-year-old woman who attends A&E at month 3, and she attends 3 times in a row in 1 week with a heart rate of 200, oxygen saturations of 85 and feeling dizzy, and she's sent home being told that it's anxiety. Long COVID is your 45-year-old male marathon runner with a normal heart rate, resting heart rate of 50, who attends A&E because he has a heart rate of 190, oxygen saturations of 79%, and chest pain which he can no longer bear. He gets admitted overnight, he gets sent home the next day, told it's anxiety. Long COVID is the person who at 12 months, having struggled to get investigations or even to see a doctor for the past 9 months, she's diagnosed at 12 months with multiple emboli all over her body. These are small blood clots. She's now in a serious situation. 12 months, and people say it's over after 3. It's your 25-year-old who's diagnosed with myocarditis, also told it's anxiety. And the myocarditis was there from the beginning. It's your 38-year-old man with no risk factors who has a coronary artery stent. And so on and so on. These stories are happening all the time. There are too many people who are 11 or 12 months are getting diagnosed with myocarditis. I'll now share my slides. So bear with me just a second. I've had some lovely pictures drawn by a person from one of the long COVID support groups who lost her job fairly early on in the situation because of a sickness absence. She describes in this picture some of the symptoms that patients describe, and I had forgotten because I haven't got them anymore. It's really common to describe a chest pain which is like an elephant sitting on your chest. You've got somebody running away after their brain saying, "Where's my brain gone?" And then there's this picture of a snake constricting somebody's chest. And if you listen to people with long COVID, they describe things which are reminiscent of other conditions. So people with MS, for example, describe something called the MS hug, which is a neurological pain phenomenon. So, and the calendar months coming off, it just goes on and on. I'm not going to say too much about this slide because it's exactly what Nisreen said. It's a multi-system disorder, including long COVID. And for me, long COVID means anyone who's had symptoms that have gone on for a long time. So I won't say more about that, as I say, because, but this can affect because it's an infection that affects the bloodstream, it can affect any part of the body, and it particularly seems to like the following places. This is a sort of image of the commonest problems. There are many more. Cardiac problems, respiratory problems, and autonomic dysfunction. Many doctors don't believe that this exists, and they actually still come out and say this does not exist, even some of the doctors running long COVID clinics. It does exist. There are specialists in this, and I think they would be very disappointed if you said this doesn't exist. I think that many people with prolonged COVID symptoms have neurological problems. It's incredibly common, including things like voice problems, which are not well known about. Massive potential impact on people coming back to work. And then there's the cognitive effects. Long COVID patients have oxygen desaturations going on for months. Mine lasted 12 months, as do many other people's. just as the same as the inpatients. I don't think that everything about long COVID is the mystery that some people make out. These things can all be predicted from everything we know about other viruses. That's my first message. My second message is because there are actually so many physical problems going on that medical assessment is essential. And I urge you to focus on those who've been 12 months sick, because they have the highest risk of trouble getting back to work and the health problems being more prolonged. I would say you need to see people face to face at least once. I'm not sure how you can fully medically assess someone unless you do that. As an example of one of the commonest symptoms, tachycardia or fast heart rate. There are many causes of this. In long COVID, it might be autonomic dysfunction, very common. Might be related to pericarditis or myocarditis, which is inflammation of the heart muscle. Abnormal heart rhythms and pulmonary emboli, which are clots on the lungs, all potentially disabling and serious. So since when in a pandemic did anxiety become the commonest cause? That's what people are being told, and that's wrong. These are the things that I think have the biggest impact on a person's function, including work. And these are the brain effects. These last quite some time, and in some people still haven't cleared up. I do think there is a trend over a few months for these to improve, but there are strange things that are very particular. There was a lady in Hong Kong, a professor of linguistics, and she did a study on several of us, and she noted that there were particular word finding difficulties, swapping of words or syllables. I think that has something to tell us about where COVID hits in the brain. Autonomic problems, in particular postural tachycardia syndrome. People are disabled. They can, after getting up from a chair to cross the kitchen and make a cup of tea, their heart rates are sky high. They come back to work and they can't do things. Pain, which is often neuropathic. Fatigue has been mentioned. Although most people have fatigue, actually, strikingly, some people don't have any fatigue at all, yet they can still have organ damage. I had no fatigue, but I've had cranial nerve problems, heart problems, and so on. Distress, and one of the biggest barriers to returning to work is that they've not been able to access healthcare, and they have not been believed. Relapses, I want to mention as a big difficulty when people are trying to return to work. This seemed to characterize the illness for some people. I think there are two types, and I don't think that's been made clear. There is an actual relapsing, remitting course to this illness in some people. It's like there are echoes of the original viral illness, and that may be resurgence of the virus, or it may be inflammation. We don't know. But those seem to be a different phenomenon from those that people get after brain or body exertion. That's got massive impact for work return. Another lovely picture. Is there a predictable pattern in long COVID? Yes, I think there are some, and this is one message that needs to get out. Month 3, between 10 and 12 weeks, things tend to either get better in some people, so that's the green on my little chart at the right, but actually a very large proportion of people continue and they get worse. As Nisreen has shown in some of the figures, which I think are really quite shocking. At 7 months, 42% of her nearly 3,000 people were unable to care for themselves or their children still. But something shifts at this time scale, and I think this demands some research. It's not my area of expertise, but I think there's some, there are known to be immune shifts that can happen at that time point. And what people get is new onset chest pain, which is like angina. Even people in their 20s describe this. They get, with that, oxygen desaturation and breathlessness. So I had angina for 6 months. It built up from month 3 until month 6, and then it gradually improved again. I saw a cardiologist who said, yes, we're seeing this with COVID. Usually the trend is to get better, but this needs managing. So 3 months, let's look at what goes on at that point. Next slide. My fourth message is non-hospitalised does not equal mild illness. I never want to hear or read the phrase again, those with mild illness who were not admitted to hospital. That is an error of thinking. You need to take the history from these people. You need to ask them, what were you like in the beginning? Because you will find those who weren't hospitalised were delirious and unable to call for help. They were told they couldn't have an ambulance or go to hospital because their lips weren't blue. They were told that they had to be unconscious. Some people had to get their dogs to bark for them because they were too ill to say anything. People weren't tested, and people have just been left out in the cold since. So take a history of the acute phase, and you might say, no wonder some of them are ill now. Nevertheless, some people did have a mild illness to begin with and yet carried on to develop all these problems.
Claire, you've got 2 minutes.
Thank you. So not hospitalised only means not hospitalised. It does not tell you whether their disease was mild, moderate, severe, or severe. Message 5, treatment is available and it helps people's symptoms. Professionals, remember your duty of care. These people need to be seen. And as Nisreen says, if nothing else, it's your secondary and tertiary prevention. So preventing the disabilities from getting worse. There are symptomatic treatments available for inflammation and allergies, simple things like antihistamine. There are treatments well used for reducing heart rates and making life more manageable, and for angina, even in young people. I doubt they'll need to be used forever because there seems to be a natural history. The autonomic problems are particularly difficult to manage, but they can be managed with various means. And we need to skill up as doctors because most of us don't know anything about autonomic problems. Pain can be managed with neuropathic type painkillers. And some people have some improvement with certain diet modifications. I like to think that perhaps had some of these people had treatment earlier, they might not be in the position they are now, because when they get onto things which reduce their heart rate and the inflammation that is going on, actually recovery can be quite rapid within a couple of weeks. We know early treatment equals early recovery. NHS, we need physiotherapists, occupational therapists, and speech and language therapists. I don't know why over the last 20 years, their numbers have been culled. But I think it goes back to what Ewan says about not focusing on long-term illness. Just finally, I've been very outspoken, so I shall continue to be so. The health system has failed long COVID patients by continuing to leave them out in the cold. We might have to ask why later. I don't think anyone would have minded so much, and they understood that the NHS was under pressure. But you cannot close the doors and leave them telling them it is anxiety after that. What we have to look at is what we do now. We have a lot of very sick people who need their basic health needs met. To not do so is unjust. I really recognise that everybody's hurting. I mean, the people that have been at work in the NHS and all the other employers have been so hard pressed. And the system's not working for anyone. So we have to change, strategically change to a system that is going to work. And that means sitting down with this large group of people who have got these problems and saying, right, how can we efficiently and effectively help you? And that isn't too much toll on the NHS. Are you going to be can-do with this problem? Or are you going to continue to say, we don't have the time, we don't have the money, it will overwhelm us, and so it's somebody else's job. It's the GPs, it's the hospital. I choose to be can-do, and I hope some of the rest of us can be. Thank you very much.
Thank you, Claire. That was really impactful. I'd like to pass on now to Lesley MacNevin, a specialist HR professional, who will explore future employment issues. So over to you, Lesley.
Thank you, Anne. And wow, I have to follow Claire after that. Just as well, I agree with absolutely everything she says. It's been a privilege to be included on this esteemed panel today representing people with long COVID. We have been made very welcome by Nick and Anne and Ewan because they recognise the role that we can play. And I guess what I'm trying to do today is explain how patients can be part of the solution, because we too have been sitting on our couches for the last year looking and expecting things to change and wondering why things haven't been changing. So it's been a slow process, but we definitely are getting there. I need to share my screen now that I've got the option. And I've got a few slides, but I'm more really trying to kind of link some of the different points that will be presented during the course of this afternoon. Okay, so hopefully you can see my presentation loading. So I think I saw it pop up in the chat there. Thank you for posting a blog that I wrote for the Society of Occupational Medicine to introduce this conference, this summit. There's a lot of granular detail in there that you can look at after the event. I'm more interested in what Clare was talking about, the patterns, and what Ewan was talking about, the systems, and how we can make things better, how we can have that we can do attitude that Clare was just leaving us with as a call to action. Our role in this is not medical, but we are and have been termed experts by experience by the National Institute for Health Research and others, because we are seen as valuable partners in finding solutions, and it's doing research and coming to conclusions and finding pathways for clinical care. I started off working with Long COVID Support, which is a huge organisation. Now you've got nearly 40,000 members in June 2020, and I was moderating the support group because I felt I was in better shape than many of the other people, and I assumed I was going to get better in a few weeks, and so this would be a nice thing to do while I was sitting at home on my couch. My symptoms continued, and so did the challenge to get recognition for long COVID. I became a media spokesperson, and most recently I've become the chair of an employment working group of volunteers from our support group who are trying to piece together all the different elements and put together the jigsaw puzzle of pieces that we need to assemble in the correct place to form the solution and shows long COVID in all its glory. I can't speak for the 40,000 people as an individual. Nobody can. We couldn't have enough patient representatives, but we have loads of people in the chat who are already making great comments. So please also listen to the chat, don't just listen to me, because we have got a wealth of experience from patients in the room, and I'm hoping I can draw on some of our experiences collectively in this session. The biggest thing I can say is we are not a homogenous group. We are not easy to fix, or we would have fixed them by now. So coming into this presentation, I created a brand new set of slides because this is a new audience for me. As I say, I'm not an occupational health professional. So when I checked what is occupational health, the piece of the definition that I first saw that struck me was the adaptation of work to people. And so I'm used to working in HR, where we have strategic HR, which is about being people first and seeing our people as our best asset. And we have operational HR, which is about trying to get maximum productivity from every unit of production. And there's sometimes a tension between operational and strategic challenges. So my passion and my absolute conviction is that the solution for long COVID is not just about doing more of the same, but it's about coming up with something new, and it's taking a whole systems approach. And fortunately, I've had a lot of experience working with large organisations, and I've got a whole toolkit of ideas that might just help. So another lovely illustration from Dormouse Diaries. This was something that was produced in June, I think, 2020, when we set up the support group to show that we're all different. If you look at our symptoms, our length of time that we've been ill, we're all different. And Nisreen, Clare and others will go into much more detail about that. That's not my area of expertise. But what we have learned as patients is to become our own case managers. So even back then, we were starting to note down our symptoms. We were starting to track the morbidity that Nisreen pointed out has not been measured by the authorities. And in the absence of other people advocating, recognising this was happening, we took the reins and worked incredibly hard collectively to get that recognition for us, which has brought us here today. We have amazing support from people like the Society of Organisational Medicine, from the National Institute for Health Research. They've involved patients in reviewing applications for research funding, in running webinars to talk about the patient experience. Myself and Joe House did an excellent webinar with another 8 or 9 others, which covered lots of great stuff, which is worth a look and is referenced in the blog. But long COVID's recent, the NIHR's recent updated report just this month has told us that long COVID is debilitating. Many of us are struggling to care for ourselves, never mind our families. And 39% said it was impacting on our ability to care for dependents, but twice as many, 80%, are finding it's impacting on our ability to work. So I ran a business. I was an aspiring writer with an interested publisher pre-COVID, and I've now become a long COVID campaigner. Because I am not in a position to offer myself as a reliable contributor to clients. But actually, in the last year, I've probably achieved more impact working with fellow long COVID sufferers than in many jobs that I had previously. So we may not be able to go back and do the job we did pre-COVID, but we have a lot of potential, we have a lot of passion, we have a lot of drive and a lot of skills that mean that we can still contribute. And that's probably the biggest message we want to take away is we have a lot to offer in terms of coming up with solutions, because we don't want to live a half-life. We don't want to be sat at home on our beds doing everything remotely. We want to get back to fully functioning adults in the working environment doing the things we're passionate about. And at the moment, our passion has become recognition, rehab, safe rehab, and research into long COVID. And we're playing a huge role in supporting the experts who are able to do that. My background is organisational development. Essentially what that means is like a massive toolkit of ideas and models and methodologies that we use with any organisation, any system. It's not about working in the NHS, it's not about working in academia, it's not about working in the private sector. Many years ago, I was head of talent for a division of a large FTSE 100 company. And I moved into the public sector because I really was passionate that we should be developing talent in every organisation of every type, and that diversity and inclusion were really important. And what we have witnessed, and I think Nisreen mentioned this in her introduction, diversity has been hit badly by the pandemic. We know that we're going backwards in terms of the worst impacts that are hitting the people who were already suffering from disadvantage. So diversity feels like a nice to do when you're in a pandemic and you're just basically trying to pay people through furlough. We can't lose sight of the fact that our workforce is being impacted. And this problem is not about the individual patient that can't turn up for work. They're a symptom. The bigger picture is that our workforce is being decimated, first of all, by COVID-19 and then by the ongoing impacts of long COVID. And you only have to look in the support groups to see the amount of talent who are currently not working in their paid jobs, but are volunteering their time and their expertise to try and solve the problem that is long COVID. We need to be seeing this as a strategic issue that is dealt with strategically. Again, the NIHR evidence has been mentioned. We know that from comparing our experiences that we do have commonalities and different clusters and patterns. We know that there's not one size fits all. There's no one solution. If there was, we would find it by now. And we don't expect a silver bullet. We're not here saying, please find the magic cure. We're realistic. And we know that we have a role to play in our own recovery. And we're playing that role every day, 24/7.
Lesley, 2 minutes.
Thank you. So we do need to make sure that we take a strategic approach. Here are some suggestions about how to make sure that you're building diversity into the solutions that you're doing with organisations. We've got a great working guide for managers that you'll be seeing online. And just come back to the patient again. We don't have to do everything well. At the Olympics, it's a team sport. We have a whole Olympic village of talent. And there's a danger that we focus on the one individual and what they can't do. We need to focus on what we can do. Coming back to that initial definition about the adaptation of work to people, please don't make it the problem of the individual who can't move, who can't breathe as well as they used to. This is about redesigning what we need our people to do at work so that they can do that while recovering. This was the updated version in December, where we looked at 9 months of living with long-term illness. As we've said, it's now a year for many of us. What is that final figure going to be? When are we going to come to an end? We've been fighting really hard for people that are not very energetic for the last 12 months, but we need help, we need allies, and we are delighted to be in a room with lots of amazing professionals who can see aspects of the solution. But it's the elephant metaphor again. The elephant isn't just sitting in our chest, it's the 6 blind men and the elephant. If you touch the tail, it's a rope. If you touch the trunk, it's a snake. If you touch the leg, it's a tree trunk. You know, every specialism is going to see all the different areas that Clare listed of cardiac, respiratory issues, autonomic dysfunction, neurological issues, neurocognitive issues. Only the patients see the whole picture. Only the patients know the full story. You can't fix us, but you can work with us, partner with us, and together we can find solutions. Please help us by being part of the light. It's been a very dark first year. We want the second year to be much brighter. Thank you.
Thank you very much, Lesley. That was very interesting to listen to and quite thought-provoking. I'd like to now pass on to Dr. David Strain, who's representing the BMA. So over to you, David.
Thank you, Anne, and thank you to the Society of Occupational Medicine for giving us the opportunity to talk. So I do have slides, but I'm going to skip them because in the interest of time, most of what I was going to say has already been said. This is a very interesting condition. So basically, I'm going to start very quickly with how I got to be where I am now, talking on behalf of the British Medical Association regarding long COVID. Because in a pre-COVID world, I was the physician supporting a CFS and ME service, the chronic fatigue service, the myeloencephalomyalgia. Can't get the words out. And it's important to say from the outset that I was not running a service, as I've been quoted as being doing, because I know full well that the occupational therapists, the physiotherapists, and the rest of the team ran the service. I was just there to look for alternative diagnoses. And then as COVID happened, we started to see a lot more referrals. We started to see many, many more patients coming through with these rather atypical symptoms, these things that didn't quite fit anywhere. And these are all patients who would now be regarded as long COVID. But as Clare and Nisreen has already said, that these are very vastly different symptoms and they come from very vastly different places. We get these patients who've been admitted to hospital, they've been to ITU, they've spent a long time being ventilated. And for those patients, it's no surprise that they've been left with post-ITU syndrome. It's very, very common. But then we are seeing more and more patients who had, I love Clare's description of it, the so-called mild, not mild disease. I myself got COVID. I spent 2 weeks at home, desperately trying to get back to work because I am also the clinical lead for COVID services in the Southwest. And as a result, I wanted to be back on the shop floor with the patients and the nurses and the staff that were busy looking after this. And as a result, as Nisreen intimated, I am one of many who is still not back to normal. And that's one of the key messages to get across for many of us here with our occupational health hat on. One of the key parameters that seems to predict the patients who've been referred to me in clinic are the ones who were so keen to get back to what they were doing before, as they caught COVID. one of the key elements, one of the key learning points is if you are unfortunate enough to catch COVID, take it easy, listen to your body, take the right amount of time to get better. The next thing is, well, what support do we get? Because you cannot stay at home sitting down and relaxing if you are also worried about paying the bills, paying the mortgage, looking after all of those elements. Within the British Medical Association, we've been very keen at pursuing this as an occupational disease, because there are many people who caught COVID in the line of their clinical role. Most of us, many of us will be healthcare workers. We know that's where we caught it, because let's face it, for the last 12 months, that's the only interaction we've had with anybody. We know that in the first month of the long COVID service being established, over 10% of the referrals were for healthcare workers. And therefore, it should be regarded as an occupational disease. We've now had clarity from NHS employers within England that for hospitals...
Occupational medicine, they had about for the long COVID.
Sorry?
It was, yeah, I paid
Kelly,
£25. So
Kelly, could you turn your microphone off, please? Thank you. There may be time to take what you're saying later when we have a panel. Sorry, David.
It's okay. It's okay. So within actually going into what Kelly was saying, that NHS employers within England are supportive of long COVID being regarded as an occupational illness and getting a 12-month support as a minimum. We don't know how long it's going to last. It could be much longer than that. And these are things that we have to be focusing on going forward. However, the difficulty there is that only really applies to secondary care. One of the big problems that we've faced when we've discussed this is that technically primary care, GPs and all of the staff that work within there, NHS employers say, well, you're not our employers, you're employees rather, you are subcontractors. And that is a battle that we are continuing to fight on behalf of the many general practitioners and the teams who work with them, the nurses, the support staff, the AHPs that are all in primary care, to ensure that they are also adequately supported. The next thing to look at is, how do we prevent catching COVID in the first place? And I'm going to cover something now that I'm sure many of you will be thinking, because long COVID has been thought to be an immunological disease. It's an autoimmune disease. And then if you trigger an autoimmune response, does it get worse? We are currently in the biggest vaccination program ever. That is clearly the best way of preventing catching COVID. But vaccination, almost by definition, increases the antibody response. The question then comes, will that serve as a reset button? Will that actually repair some of the autoimmune damage that's been going on? Act as a reset button and make symptoms better. For other patients, however, is that going to irritate the inflammation that's going on? Is it going to make them get worse? And clearly, that's a very important question that we need an answer to, because vaccination is likely to be the best way out of here. And for those of you who are experiencing long COVID and who've been vaccinated, we would really value your opinion about how it affected you. I've just put a link on the chat bar. Please do feel free to comment on that. So far, we've got 650 or so respondents who suggest that some of the symptoms get dramatically better: the fatigue, the pain, the shortness of breath, and the brain fog. Other symptoms appear to get worse. I'm seeing many of you shaking your head or nodding your head. Please fill out this form, because this is something that we really need to know. And then the next step is, how do we go about treating it?
You've got 2 minutes.
I'm just wrapping up now.
Thank you.
The next thing is how we go about treating it. And this is where my other role is, that in a pre-COVID world, I was planning research studies in CFSME. We are now hoping to expand those to determine not just what the underlying causes are, We've already seen a programme of nearly £20 million is being invested in describing long COVID and describing the pathology of it. But the next step is going to be, what are the treatments? There's one or two anecdotal reports, one or two treatments that people suggest work for them. The big problem we have at the moment is nobody really knows the natural history. So until those treatments that people are reporting, whether it be a vitamin supplement, whether it be sunlight, as we clearly have for the first day of the year when I'm trying to do a presentation in front of a window, all of these things, whatever the treatment, we need to put them in through the randomized controlled trials. And that is going to be the next step. And I'm sure if you weren't aware, NIHR have just launched another £20 million to try and look for those treatments. And hopefully, in the not too distant future, we'll be back here telling you what the optimum treatments are. But the very last message for those of you who are working in occupational medicine, occupational health, who are dealing with these, just please listen. Many, many patients are telling you what's wrong with them. It is not anxiety. It is not in their head. It is not depression. It is not a whole host of just buck yourself up and eat a little bit better. This is a serious medical condition that requires investigation. It requires listening to potentially other investigations, and then it requires some form of treatment as soon as it's available. And I want to thank you all, and I'm hoping that we'll be around for lots of questions later on. Thank you.
Thank you, David. That was really interesting. I'm sorry I had to hurry you up. We do need to keep to time. We now have another David Petrino, who's head of rehabilitation at the Mount Sinai Hospital in America. So we'll now be getting a US perspective. So David, welcome, and thank you. Over to you.
Thanks for having me. You know, just to keep things comfortable, you're getting a US perspective from an Australian, so we're keeping it in the Commonwealth. I am going to share some slides. I actually, given everything that I have heard so far, the slides that I'm going to share, I actually made while we were talking, because there's been so many phenomenal shares so far, and I don't feel the need to repeat what has already been said, because I wholeheartedly agree with everything that has been said so far. So I just want to start by saying how long COVID, or what we've been calling at Mount Sinai post-acute COVID syndrome, landed on our radar. When COVID really hit New York hard in March, we rolled out a remote patient monitoring service for individuals who were experiencing signs and symptoms of COVID, but could not get into the hospital. So very, very similar to what Claire was saying. I'm not saying that these people had non-severe COVID, but I am saying that they did not meet criteria in a crisis for being admitted to hospital, which is quite a different thing. We had a remote patient monitoring program existing for stroke survivors. We clicked over a period of 24 to 48 frantic hours, we rejiggered it for COVID patients, and we started doing a lot of monitoring at home. Now, the first thing I want to show you, because it's so important to point out that these individuals, many of these individuals, didn't have a PCR test. They didn't have an antibody test. PCR tests weren't even really a thing when we rolled this out, which is March 16, 2020. And what we showed in this first study by Tabakov et al. Was that individuals, regardless of their PCR status, really the only thing that changed was their self-reported anxiety. As you can see, people who are PCR unknown were really anxious because they didn't have an answer for why they were feeling so terribly, but everything else was not significantly different. We were able to show that by using this remote patient monitoring tool, we could keep people in the home, keep them safe, and keep them from serious detrimental health effects, and keep them out of hospital. So that was our remote patient monitoring program. And I think as we start to think about why long COVID is why it is causing all of these symptoms. Rather than talking about people with non-severe or less severe or whatever the case may be, COVID, I think a term that we might want to throw out there is passively treated. So individuals who did not show up to the hospital and get a ton of steroids for their cytokine storm, people who didn't get active medical treatment for their COVID, rather they were passively treated. And that is a large group of people who were either asymptomatic all the way through to incredibly symptomatic, but during the crisis were not able to get a hospital. So we see in these people with persistent symptoms? Well, we're seeing lots and lots of symptoms here. And these are all publications that you can look up online. But this is a cohort of around 100 people that we looked into. I want to take a beat to do a real shout out to JAMA, BMJ, New England Journal, who editorially rejected work describing these symptoms because we included people who were PCR negative and antibody negative. Now, we had the opportunity to publish similar data only using PCR positive and antibody positive patients, but we refused to do so because that is not an honest and authentic representation of the population. So shame on journals that bring that up. And if there are people who are editorial members of journals, please take this as a lesson. You need to include everybody. We need to be all inclusive. This is an entirely novel condition. It is inappropriate not to include everybody, regardless of a testing status that has known flaws. And how do we know that it has known flaws? Because now that the vaccine is rolling out in the US, what is the CDC saying? Don't trust a negative antibody test post-vaccine. You still have immunity, even though you have a negative antibody test. So let's keep that in mind when someone suggests you should turn away a patient that is showing signs and symptoms of long COVID, but has a negative antibody test or a negative PCR in their medical history. So again, you guys have heard all of those symptoms a lot. I really want to zoom in on two things that I think are interesting that seem to be happening in all of our patients. First is hypocapnia. Shout out to Jamie Wood and Josh Dunce, who actually are part of our sort of post-acute COVID team, who really found this relationship. But almost every, well, actually not almost every post-acute COVID patient we have tested so far is showing end-tidal CO2 levels that are below normative values. So they're sort of sitting in the mid to low 20s. So we found that this was a really interesting finding. It has guided a lot of our initial therapeutic interventions to good effect. The other thing that we're starting to see also is reduced LV dimensions in echo. Now, unfortunately, in most cases, we don't have pre-COVID echoes in most of our patients, but what we can see is these are normal echocardiograms. These are within normal limit LV dimensions, but similar to what we see in dysautonomia populations, these individuals are showing on the lower end of normal. The population effects that we're seeing here are reduced LV dimensions. I think that's something really interesting to note. Our quick treatment pipeline. We do an initial evaluation with a physician. We immediately go for cardiac clearance. These symptoms look a lot like pericarditis. They look a lot like myocarditis. We clear that with a cardiac investigation. We refer to prehab with breath work using protocols that have been developed by certified breathwork coaches to encourage CO2 retention and CO2 tolerance. Additional specialties as needed, psychology, nutritionists, etc., and other specialists to deal with specific organ damage. And then referral to physical therapy for what we're calling right now, very unimaginatively, the approach model, which is an autonomic challenge protocol that we have developed for these patients. So, you know, and this is the same information presented another way, really just focusing on the idea that first we evaluate everything, then we work to stabilize symptoms. by bringing in an interdisciplinary team. And then we move into reconditioning through our protocols. I just want to shout out to the nutrition piece here as well, and really state that nutrition here has been primarily focused not on creating restrictive diets and saying these foods go against you, so on and so forth. We've been having better success actually with intuitive eating approaches that focus on actually assisting patients in weight gain, because most of our patients are malnourished at this point because food can be such a trigger and they feel unsafe eating, so they don't eat anything. And that really places them into a very unhappy cycle. So working closely with a nutritionist has been really handy there, but it might not quite be what you think. We're not creating a PAX diet. We're really focusing on intuitive eating approaches.
David,
so I want to
2 minutes.
Okay, 2 minutes. I want to share some really interesting data here. So we have a group of people who did not get PT for various reasons, just including we couldn't schedule them in time. We have a group of people who did receive our PT protocol. These two groups had no significant difference in their baseline patient-reported outcomes. And then we followed them up around, on average, 160 days after we captured baseline outcomes. What you can see is that in fatigue and pain, we're seeing some significant changes in the PT group versus in the no PT group, we're not seeing these changes. So we're seeing basically people stay around the same, maybe a little worse, maybe a little better in the non-PT group, whereas in the PT group, we're seeing significant improvements, roughly around 30%. In our EQ5, which is a sort of a health and lifestyle a patient-reported outcome, we're seeing across the board improvements in the EQ5 in the PT group, some significant improvements, whereas in the no PT group, we're not seeing improvements. In the visual analog scale for the EQ5, which is just overall health, we're seeing a significant improvement in the PT group. We're not seeing an improvement in the no PT group. And finally, in the patient global impression of change, what are people telling us? In the PT group, we get a median score of 5, which is a small but meaningful difference. In the no PT group, we get a median score of 3, which is no change whatsoever after 160 days. So I present these data. This is not a victory lap. We're not saying that we're doing a good job here. We are saying that people are responding to a therapy that we developed that was based on existing literature about post-viral syndromes and existing approaches that have worked in the past. However, I do want to highlight that we're talking about influencing symptoms by 30% after 160 days of rehab. So this really should tell us the magnitude of the problem that we're dealing with, and that we need to do a lot better and a lot faster and really keep pushing at it. So I'll finish there by just acknowledging a ton of people who came together at no notice whatsoever to build an entirely novel rehab paradigm that appears to be working, and also thank all of our patients who have just been, wonderful, patient, and understanding of the fact that we're dealing with a once in 100-year crisis, and they've been incredibly gracious with us. So thanks very much.
Thank you very much, David. And I'm glad you acknowledged your wife. I think she's probably supporting you a lot more than many of us realise. Okay, so thank you, Claire, Lesley, David, for some really interesting and multi-professional perspectives of long COVID. Now, I'd like to pass on to the next segment. I'd really like to congratulate the speakers that we've had thus far. We've had 2 extremely thought-provoking segments, and we'll move on to consider some non-clinical facets from the perspective of the government, the NHS, the DWP, Stroke Department for Health and Social Care. The speakers for this segment include Alex Norris, MP. He's Shadow Under Secretary of State for Health and Social Care. Nick and I have had a few meetings with you and Sir Keir Starmer, so we really appreciate your contribution to this online summit. And following you, Alex, is Kathy Hassel from NHS England, and NHS improvements. So first of all, I'll hand over the baton to Alex Norris. Thank you.
And Anne, I will gladly receive that baton. Thank you very much for having me, and thanks to the Society for putting this event on and for your leadership in this range, as well as the university, and of course Professor Macdonald, all good friends of mine, and I really appreciate the chance to collaborate with you. As Anne says, my name's Alex Norris. I'm Member of Parliament for Nottingham North. I'm here in sunny Nottingham as we speak, and I'm the lead for the opposition on public health matters, and have taken in a long interest in long COVID. I always look, certainly, a long conference like today, I'll look and see where's my place in the world, because having sat in on most of the last session and having seen the speakers that come after me, I try my absolute utmost not to duplicate, not to replicate things that they would be better than me at, which is anything to do with certainly the clinical side. So I'm going to talk to you a little bit about where this lands politically. Now, not in a partisan sense, or certainly not in a party political sense, but just to hopefully to share with you my insights about how things change in the UK, what it takes to affect change in politics and in Parliament. So that might be an asset to the work that you're doing. I mean, first of all, the first thing I would always say is to motivate and to build a coalition of willing and interesting people. So it is incredible actually to look at that participants number and to see just how many people there are. And I was having a quick scan of the list, the length and breadth of the UK, but actually internationally too, all sorts of disciplines and experts by experience. So you're already doing something truly exceptional, certainly for something that as David just said, a year, 15 months ago wasn't even on our radar. That is truly impressive. And it starts from there. It follows the basic question: why should politicians care? I mean, I first got interested in this probably 3 or 4 months into the pandemic. I got a phone call from a former Member of Parliament colleague of mine who's suffering from long COVID. Said, Alex, there's something going on here. You need to understand. You need to take time out to kind of engage with. And at that time, my engagement was with big groups of people on Facebook. And now to see how things have organised and campaigns have developed and experts and expertise have come forward, I think is a really remarkable thing. But I do think the case for Westminster politicians to care is a clear one. What I'm sure you've had lots of metrics, so we can all find our own numbers, but we know that we're around that 1 in 4 25 to 69-year-olds who've had COVID have had this. So it doesn't take much of a genius to say that if you've had 4.3 million positive cases, which we know will be only an aspect of how many people have had this virus, you're talking a really significant number of people are going to be suffering from an extraordinary panoply of related conditions that they will live with for some time and perhaps for the rest of their lives. That is, for me, really significant. It has profound implications for those individuals and their lives, which is why it matters at its basic level, but also for society. It has got implications for the NHS, for DWP and the world of work in general, and for social care, any aspect of public life. I think this then touches. So that, I hope, has acts as a call to action for politicians. It certainly has for me. And also we know, because what we learned today that we didn't know 12 months ago? Well, 12 months ago we were saying, well, COVID, it's not going to be a respecter of your postcode or your profession or your ethnicity. It's going to be a great leveler. Well, we know that's not the case, and we know that those who are most vulnerable are the poorest. We know it skews towards those who are from Black, Asian and ethnic minority backgrounds are more likely, and of course frontline staff. So you think of the profound implications this has for, say, the health service and for our social care workforce, that we know that this is a really challenging and really knotty long-term condition that is associated now with a lot of our, by definition, the people we've been calling key workers for a year. Again, I think that acts as a call to action, and I think we have to keep telling that story. So I was doing my tick list really of politics and how to affect change, as I said. Firstly, you've got to land the issue, and I think that has happened. I think the fact that you've got so many people here and shows you've landed the issue. The fact that actually the next speaker to me is Kathy, obviously a very important person in our primary institution in this regard. The NHS E&I is here is a great sign actually of how well you've landed this issue. So I think there can be a lot of, you can take a lot of pride in that. Similarly, we've had a parliamentary debate about this, which, you know, I know debates are debates and it's action that we want rather than talking. But I also know that if I look down my meeting schedule for this week, I would find 10, 15 issues of groups relating to issues that I'm meeting that would kill for a parliamentary debate. So again, it shows, I think, the strata that you're engaged in. Similarly, the first day back after Easter recess in Parliament will be health and social care questions. I can guarantee there'll be a question on long COVID. There has been for the last few sessions, again, because it's at that level in MP's mind. So I think that's really, you know, a really, really good sign, and something that you can take a lot of pleasure in. And I think, you know, also to take pleasure in the successes that you've had so far, you know, around the specialist clinics. That is no mean feat in the period of time we're talking about, to generate pressure and then action to get 69 specialist clinics. We think the government are right to do that, and we support them in doing that. And then similarly, the support around research that's been won. I know you want to go further, but again, that is no mean feat at all. So that, you know, I think you should take real solace and real pleasure from that. So where might we go next? I mean, first of all, I think a bar to aspire to, or you know, a challenge and a hurdle to clear. We've got to do better than a normal long-term illness, in the sense that I don't think we deal with long-term multidisciplinary illnesses in this country very well. And that's no criticism of anybody. I think that's the reality. So that a novel condition starting from scratch, it is reasonable to say that there should be novel from scratch solutions to that are multidisciplinary, that are patient-centered, and these things in a meaningful way, not in a way that comes out as kind of alphabet soup. You know, particularly to have a look at how we manage long-term illness around the world of work. You know, as a member of Parliament, I deal with lots of people who have not very nice work capability assessments, employment support assessments, and that process is horrible. I don't think it's humanizing. I don't think it's kind. I don't think it's enabling. Again, we should be looking to do much better than that. It would chime in, and with the SOM, my good friend, so I would not get out of here if I did not say this, that around occupational health too, around that disparity, depending on your employer as to the quality or indeed any at all occupational health you have, they're going to be a really important driver in understanding and having thoughtful, tailored and individual responses to the challenges people are facing at work. Similarly, to press hard on a multidisciplinary response, you know, the full NHS family, OTs, physios, all the clinicians, you know, again, starting from scratch, there is no excuse not to do those things. I think we should be aspiring to those and pushing quite hard on that. And then, as I say, particularly around a patient voice, I think the patient voice is rich and strong. I know we've got many experts by experience on the call today. But we should be looking for that to be really centered in the approach that we take. People have had to cry out to get to be listened to, and they've done an amazing job. It should not now be a case of, okay, we'll take that off you and we'll come up with a systems approach that suits us and we hope you can fit in with. I think we can do much better than that. So and I think I will put a pin in it there by concluding to say, I think we, you know, colleagues on this call can reflect with real pride about the progress that has been made over the last 6-9 months. You know, you look back sometimes when these things happen and you think they're inevitable. Nothing about what you've achieved has been inevitable so far. So that's a good thing, but that should only raise aspirations for what you do next, because there's nothing inevitable about what comes next. You know, we might be in violent agreement that this is a thing, which was a challenge in itself at the beginning. We might be in violent agreement that it's an important thing. We might be in violent agreement that something ought to be done about it. But after that, the rest is what we paint on that canvas. And, you know, as I say, I'm the opposition. I wish I was here as a government minister here to, you know, do some deals and agree with you what we're going to do. But I'm not quite in that position at this moment in time. But what I would say is, from my point of view, we're very, very keen to support you. We're very, very keen to give a parliamentary platform to your ideas and your issues. You know, we've been with you so far and we'll be with you the rest of the way. And, you know, so keep going. And I started with 435 people on the call, and before I was now I'm 429. That's not bad. That's it. I wish I'd only lost that percentage on my vote last time in the general election. But before I lose any more, I might stop there.
That's lovely. Thank you so much. Your timing is brilliant. We did have an interesting conversation with you and with Sir Keir Starmer about the need for universal access to occupational health. And Ewan, that's something that's a passion of his. So I'm more than happy to come back to you on that. And particularly if you want to put pressure on government by asking difficult questions, I'm sure we could give you some pointers in relation to pursuing that. Thank you so much for your time. I'll be thanking you again at the end of the next presentation, which is from Kathy. Kathy, I'd like to welcome you. Kathy's from NHS England and NHS Improvement. So over to you, Kathy.
Many thanks. Thank you. So I'm Kathy Hassel. I'm Director of Clinical Policy and Quality at NHS England and Improvement. And I was given the job of being responsible for the NHS England long COVID plan. We, in response to growing testimony from people with lived experience of long COVID and clinicians who were telling us more and more that, that they feared that we would be having to manage COVID-19 as a chronic condition, we last summer we worked with Leicester Trust to develop a website called Your COVID Recovery to help people recovering from COVID-19. The feedback grew and grew, and so in October we launched the initial response to long COVID with our 5-point plan. So the 5-point plan involved a few things, and I think we've made some progress in each of those areas. So first of all, it was to rapidly develop a clinical case definition and clinical guidance for healthcare providers and clinicians, and to help them support patients who were struggling with long-term symptoms. And so what we did was we asked NICE in England. This is I'm referring to the actions that we took in England. So we asked NICE to look at the clinical case definition. We felt this was really important, so that people could get acknowledgement that that their condition was real, and that then that would lead into actually developing some clinical guidance that would support clinicians to be able to identify and then treat people who were unwell. So that was published in December. That's the NICE guidance. The NICE worked with the other 3 nations across the United Kingdom to develop that. Again, I think NICE would say that was their initial response to it, and I know that they're going to be reviewing the guidance in the spring, and will update in line with any new evidence on treatments that work and so on. In addition, to improving information about the condition, we also worked with the Royal College of GPs, who published a fact sheet spotting and managing people experiencing long COVID, and Health Education England published a package of online training to help healthcare workers to manage and support affected people. We also, our mental health team also developed some on e-learning packages for to be delivered to therapists who work in improving access to psychological therapies. So that was the initial response. I think there is much more to do, and as people have commented, the NICE guidance would need to be updated in line with any new evidence that they see on what works in tackling this. The second point of the 5-point plan was to establish post-COVID assessment services. So we did that. We announced at the end of 2020 that £10 million, the £10 million that we had invested had gone towards setting up 69 post-COVID assessment services. The important thing about these services was that they should provide a specialist physical, psychological, and cognitive assessment, and give patients access to a multidisciplinary team to reflect the multi-system nature of long COVID, and to make sure that it was a truly specialist assessment and diagnosis, and then to get people into the right treatment pathways. we have we've recently confirmed that we'll be continuing that funding and that those services will continue into our next financial year, which starts on the 1st of April. The other thing to say is that we will be announcing further clinics that will be opened around England, to make sure that all parts of the country are reached and that people can access those services wherever they are. Third point on the 5-point plan was to extend the Your COVID Recovery online platform. So I think it's safe to say we've had 1.2 million visits to the Your COVID Recovery website. The second phase of that was to open the website up to offer a more specialised online recovery platform for people who had a clinical consultation and then could be referred onto the online rehab platform. That does require clinical supervision, which is why you need to be referred into it by a clinician. But more lately, we've been transferring some of the content from the online rehab section to the wider website to make sure that as many people can benefit from it as possible. The fourth point on our 5-point plan was to support research. So we've mentioned this a few times. The NIHR have now announced 2 calls for research and put in the £38.5 million to long COVID research projects. We're working closely with the research leads so that we can use the learning that's coming out of the research projects to inform the development and evolution of healthcare services. I mean, everybody's pointed out that nobody is really sure, definitively what works in terms of treatment. There is no large-scale consensus globally on what works in terms of treatment, and that's why it's so important to have more and more research. The other thing that I think is important for us is that we start to see the results from the research as soon as possible. I know some of them are 2 to 3 years. That's too long for us to wait. We need information now, and when it's ready at intervals as the research goes on. And then the 5th point on the 5-point plan was to establish a long COVID task force. So we have done that. We've established a national task force, and I've noticed many of our members are also attending this today. I would say on this, thank you so much to all of our task force members. It brings together patient representatives, clinicians, researchers, people from charities, and they all come together to work to support implementation of our 5-point plan. There are about 100 members, and I think we have some representatives from the other 3 nations on our English task force, and everybody's very welcome. And as part of that, we've established a subgroup which looks at health inequalities, so particularly access to long COVID services, experience of long COVID services, and outcomes. So what's next for us? As I said, the 5-point plan was the NHS in England's initial response to the growing healthcare challenge that is long COVID. What we want to do now is have a clear clinical pathway, a care pathway that there is some consensus about, that wraps around the post-COVID assessment clinics to make sure that holistic care is being delivered for the people who are experiencing long COVID. There is coordination across the care pathway, but it's not just about referral and having that specialist diagnosis, but also making sure that people have rehabilitation and treatment and so on. And I think the care pathway is something that healthcare professionals tell us they really want. They need to understand what works and what good practice looks like. Another thing that we're focusing on at the moment is guidance on long COVID to support NHS employers. So more information about what it is, what do we mean by long COVID, and what should employers look out for, and be making sure that they're adapting for their staff. And that brings me on to support the staff. So we have announced, in response to the pandemic, a package of services for NHS staff. We think that healthcare staff may have been disproportionately affected by long COVID. And it's important that the NHS role models its approach to supporting people who've been affected by this. The package of of health and wellbeing support services for NHS staff was launched at our board meeting last week, so the 26th of March, and it can be found at www.people.nhs.uk. It includes 40 mental health hubs that have been established to give staff rapid access to the care pathway, all care pathways. Enhanced occupational health services and wellbeing pilots are taking place in systems covering 700,000 staff. And staff can access occupational health teams either on site or remotely, with onward rapid referral to other services where needed. These will augment local health and wellbeing support services that already exist. In addition, we are promoting the Faculty of Occupational Medicine's guidance for healthcare professionals on return to work for patients with long COVID, and guidance for managers and employers. So I think there are, resources out there, and we're trying to signpost to them as well as develop our own services as well. Another priority for us over the next period is the learning network. So we've established a learning network for healthcare professionals, so that they can share information about what has worked in their patches. There is some variation in the clinics. We have a core criteria for the clinics, which is set out in our commissioning guidance, but we also know that some innovative solutions have been developed locally as well. So we had at our last learning network, we had a session on post-COVID assessment clinics, which are run by allied health professionals and focus on rehabilitation and actually provide a 12-week package of rehabilitation support for the people who are that they're seeing in their clinics. And we just want that to build on that learning network, because we're all learning about this condition and how to treat it. And then finally, for us, data is incredibly important. So I mentioned the work that we're beginning to do with the research projects on long COVID. We want to make sure that our work is mutually beneficial, that the data that we have is supports those research projects, and that we also learn from the research. So for us, collecting data on access to the post-COVID assessment services, so that we can make sure that there is it's fair and equitable, and that we can see that all of the post-COVID assessment services are being used, and that the rates seem to be consistent with the levels of infection in those areas. And also monitoring data on access, because we want to be able to see if people who are most likely to be affected by health inequalities are accessing those services. So demographics like ethnicity, gender, age, that kind of thing, because the clinics are meant to be there's meant to be provision for people of all ages, including children. So we're keeping an eye on that. We also want to track data on outcomes, so more longitudinal data. So which pathways are these patients going on to be treated through? What tends to be the most common type of diagnostic, and what tends to be the most common type of treatment? And then what are the outcomes for those patients? I mentioned the learning network and the rehab-led services in parts of the country. They're seeing some small cohorts, but some evidence that there are improvements when people are put on a rehab pathway. And we need to develop all of that. We need some, large-scale quantitative evidence around, what works and improves outcomes. And then finally, collecting information about patient experience, so the people, firstly, being referred from general practice, and then people going through those clinics, how they feel about those services. Lots more to do for us, but we are, taking this very seriously as an organisation, and the NHS, I think, given all of the other pressures it's been facing, like acute COVID pressures and rollout of the vaccination programme and recovery of other services like cancer and so on, is rising to the challenge, and we're starting to ramp up long COVID services. So I will end it there. Thank you, Anne.
Thank you again. Perfect timing. I'd just like to thank the two of you. So interesting to listen to you both. I was pleased that both you, Alex, and you, Kathy, referred to occupational health. Occupational health is going to be so important. We know we're important, but it's now brought us to the attention of others, particularly thinking about people with long COVID, whether they work as teachers, in the transportation system, retail, and the NHS. We're going to be absolutely crucial to helping those people return to work or stay at work. And it was music to my ears to hear both of you refer to occupational health. So now our penultimate session, and that's going to consider the challenges associated with return to work following long COVID. Please, if you've got any questions or comments that you would like to be addressed later on, if you could put them into the chat box, Nick will then collect them together. So our speakers for this next session include Dr. Tony Williams, who's going to provide an occupational medicine perspective, Dr. John Etherington, who'll be considering rehabilitation perspectives, Colette Owen, who'll focus on physiotherapy, and Deborah Edwards, who'll be considering vocational rehabilitation and early interventions. So over to you then, Tony.
Thank you. I will just get my PowerPoint up and have it running. Good. Now, the first thing is I'm going to apologise, but I'm not going to give you the answers today. I'm going to raise a number of issues, but I'm not going to apologise for saying things that have already been said. There's a number of things that I agree with wholeheartedly, and I think it's really important if you get a number of people saying the same, giving the same message. First of all, looking at my workload, I've definitely seen a lot of cases. About 25% of my workload now are long COVID, but over half of those who were hospitalised, they really were extraordinarily ill. The other half who weren't were also, most of them, very, very unwell. And I would echo the points made. It's common for people to say, I was in bed for 4 weeks. I didn't go to hospital, but really very, very unwell. And long recovery times would be expected. But I think the main point is that of each case I've seen, they're all different. I'm not seeing one definite trend. I'm seeing people with remarkably different symptomatology, a lot of really severe pathology, but it would be wrong to say we've got one group who are all much the same. And I am concerned, looking at the NICE guidelines, that they seem to be suggesting a binary approach. Either you've got pathology or you've got long COVID. And I fundamentally disagree, because I don't think that's scientific. I think it's perfectly reasonable for people to have both, to have severe lung pathology, for example, and also to have other symptoms of long COVID. And I think it's wrong to try and separate people out. But I do think we need to be very careful about diagnosis and assessing the degree of impairment in each individual. But we also need to look at work. And one of the issues I'm seeing is the impairments we're hearing about very much depend on the job. And we know cognitive impairment's a problem, but it may not substantially affect people in manual roles. And the opposite will apply, that if people are in sedentary roles, things like breathlessness may not be a problem. And I'm worried that when we see the lifting of lockdown and people coming back to work, an awful lot of people have been able to cope because they've been working from home. And we may see a big increase in people struggling when they've got to get into work. But certainly we're going to see a huge impact on business, not just sickness absence, but a lot of the organisations I support, the employees have to do physical things, and physical limitations will prevent them from doing their core job. That's going to be a huge issue for those organisations. And cognitive limitations, I'm seeing doctors, I'm seeing academics, I'm seeing managers who are really struggling with cognitive aspects. Mainly, they're very slow to make decisions, they're slow to produce reports, and that will have a big impact. And then we've got the self-employed, and it's going to be a huge issue, and it's one that we're going to have difficulty getting visibility of. But the most important point for work is the risk of long-term absence. And we've heard of that already. We know that after 3 months of sickness absence, the likelihood of returning declines. And by 6 months, there's a very small likelihood of coming back to work. And we've got to be very careful to keep touch with people, prepare for a return so that we don't lose people at the 6 month point and find difficulty getting them back. There's individual concerns. And I think one of the big problems that we've highlighted already is a lot of people are impatient. They've been very, very unwell. They've been off work and they're keen to get back, and they come back much too quickly, and they try and come straight back to doing full-time work. And that is a problem, and it may well be a major part of why we're seeing long-term problems. There's a lack of understanding, and many of the employers I'm seeing are very anxious. They're really worried because nobody really knows what's going on, and we need to be able to tackle that anxiety. But if there's going to be anything that I see commonly, it's the substantial loss of fitness that we're bound to see, but also the shortness of breath. But there's a worry, and I'm concerned about those in physical roles. If they've got significant cardiac problems, there could be a real risk of them developing further pathology to their hearts if they go back to a physically demanding role. We've got to be able to measure and exclude them from those particular roles until they're fit and ready. We also need to be able to assess and manage cognitive issues. And my problem there is, how do we assess those in an appropriate way? And I think finally, something we must acknowledge is there are patients who feel no one believes them. We've got to listen to the patients. We've got to listen to their story and listen to their symptoms and manage those. And we mustn't just put them in a box. We must assess each individual symptom and try and tackle each one and come up with tailored solutions. So talking of solutions, what we really need in occupational medicine is simple tests, objective measurements, and we have a number of things we can do. I'm surprised at how many patients tell me they've already gone out and bought a pulse oximeter, and they can tell me the results. But not just that, they can tell me how they're measuring progress and the improvements they're seeing. And that's something we need to take on board, but we also need, as I say, simple cognitive tests that are meaningful. Currently, the ones we tend to use for dementia really are of no value in measuring the more subtle issues with cognition. We need something to support the self-employed. They don't have access generally to occupational health, so we've got to have something else in place. We've heard of long COVID clinics. Now I'm hoping that they will provide much more detailed assessment, but where are they? Now I'm in Kent. I was told a couple of weeks ago that they finally agreed where the long COVID clinic is going to be, but that's as far as they've got. There are no other plans so far to my knowledge about who's going to be staffing it, who's going to be involved. And there's a very real need to refer people now. But another point we must take on board is that most of the patients I'm seeing have had their symptoms often for several months, and they've already started to work out what works for them. And we need to listen to that and help them continue to do what they're finding works best for them. So return to work. For most of them, this is our bread and butter, and it'll be straightforward for those who are going to progress well. We just need to continue with that progression, but it's got to be tailored. And I did see some of the comments coming up about the typical, well, we're allowed 4 weeks of phased return. That's got to go out the window. The phased return has got to be as long as it needs. It's got to be the right approach for the right patient. But also we've got to be able to integrate that with the rehabilitation in long COVID clinics. There's got to be a link, and that's got to be a workable link. One of the key messages for employers is that we may be looking at redeployment. There are a number of jobs where people are definitely not going to be able to return to that role, but they can come back and do something else. But we also need to identify those who may never be able to go back to that role. We need to be looking for obvious signs of pathology where we can actually predict. And I've seen a number of patients who've really got profound lung damage, profound brain damage, profound cardiac damage. And we've got to be able to advise early on what they're likely to be able to do. But also that redeployment or the phased return may need to be very long term. And we've got to be prepared for that. And for many employers, they can't afford to have somebody on full pay and on reduced duties for a long time. So either we've got to find extra funding from somewhere else, or there's going to have to be a change of contract for that employee, because that often takes the pressure off for them to get back to their job if they're allowed to continue on suitable work for the long term. We've also got to look at beliefs and expectations. And this is really important to acknowledge. There are some who won't understand what's going on, they'll be very anxious, but some are coming to me expecting to be permanently disabled. They've been told they're never going to get better because of the information they found on the internet or from support groups. So we need to be able to deal with that belief. And for many, there's no medical reason why they can't make a full recovery, but we do have to acknowledge that some will be unable to do so. We need to get away from a purely negative message. And most importantly, and this is a concern for me with ill health retirements and so forth, is how are we going to deal with those who've had no objective evidence of infection? Are they going to be able to access ill health retirement or long-term financial benefits?
Tony, 2 minutes.
I've finished, that's fine.
Oh, perfect.
Great.
Thank you. Thank you very much. I can't believe how well people are timing themselves. That's superb. Well, what can I say? Next person is Dr. John Etherington, who's going to be talking about rehabilitation perspectives. Thank you. So over to you then, John.
Okay, oh, I hope you can see that. So I'm going to whistle through the issues around rehabilitation, and I'm a couple of perspectives. I'm currently the president of the Faculty of Sport and Exercise Medicine, and previously been National Clinical Director for NHS England for rehabilitation, so I have a little insight into that as well. Now, in my experience, the principles of successful rehabilitation are based on these factors. Now, you can debate these, but my experience is that these things work. Early assessment of the case, active case management of individuals on a day-by-day basis, and making sure what you plan to happen happens. Working with a good multidisciplinary team. The capability of delivering exercise-based rehabilitation, and in the military context, group therapy. And quite importantly, having rapid access to further specialist opinion and investigations when you need it. One of the challenges I've seen in patients with long COVID is that you're trying to develop this multidisciplinary approach. People have a very complex set of symptoms and presentations, and then for getting a consensus from the chest physician, the cardiac physician, the neurologist, the rheumatologist, etc., as to what is going on and whether it's safe to proceed is very difficult, time-consuming, and often people don't know. I've put down here work, occupational health and employers. That's stock in trade within the military, but it's less easy to affect as a clinician, either in the private sector or in the NHS. And any rehabilitation plan should be delivered by an MDT. And again, looking at my personal experience of this pandemic, but also rehabilitating lots of other things like anything from massive trauma to brain injury to mild traumatic brain injury to post-illness rehabilitation, is that you need a good MDT because you can't do it yourself. And in particular, in this context, you will need physiotherapy. Occupational therapy, the right approach, is absolutely invaluable, but all of these things are important. But do you have this? Have you got access to this? And as we've alluded to before, we need to measure outcome. And I have always advocated return to work is a very important outcome, as are other measures of general health, which we've heard about today, like EQ5D or measures of goal attainment. Now, a colleague of mine, Jonathan Korgoankar, is a consultant in sport and exercise medicine. He runs one of the post-COVID clinics that's been discussed here, and was initially set up for people who've been very severely debilitated as a result of long periods on intensive care, often been in ITU for many weeks or months, and they've been followed up by the ITU team and also the physio rehab team and sport and exercise medicine. But increasingly seeing people from GP with no previous hospital admission, with a variety of different symptoms: persistent fatigue, reduced exercise tolerance, neurological symptoms, MSK problems, musculoskeletal problems, and a very limited framework by which to treat them, both in terms of the knowledge and the capability that they have to deliver the treatment. In often people who are incredibly debilitated, who have never been inside a hospital. Now, the COVID assessment clinics are there. They are running. There's something like 65 of them, and there are, I think, £10 million allocated to their running. The reality is that, for example, I know that in Jonathan's clinic, people weren't getting paid to do that clinic. It was a free provision. That's not likely to be very sustainable. We've heard, obviously, about the NHS offer in terms of long COVID and in particular the rehabilitation. Now, Your COVID Recovery, the website is very good. It does have a focus more on respiratory conditions than others, but then it was written by a national / world expert in pulmonary rehabilitation. It's good, but it's a website. The Faculty of Sport and Exercise Medicine have provided some resources for patients recovering from COVID, and the Moving Medicine Initiative is generally targeted towards healthcare professionals who are trying to give advice around physical activity, illness, prevention and management. It's a website. And these are the national guidance for post-COVID syndrome assessment clinics. And what I would say is that they are very detailed. I've read them in great length. It tells you how to assess people. I don't believe it necessarily gives you the resources to assess them properly. And most of the reflection is, when in doubt, refer to the NHS rehabilitation services. Now, NHS rehabilitation capability tends to be relatively stovepiped into certain areas, such as pulmonary rehabilitation, cardiac rehabilitation. It has limited capacity, and this is what I will show you now. So this is relatively old data, but on pulmonary rehabilitation. So 1.2 million people, even before COVID, have symptoms or disease which warrants referral. Only about 15% of them ever get referred for rehabilitation. And a study of 7,500 patients showed that about 37% of those before COVID were waiting 3 months or more for treatment. So you really only got about a capacity of around 50,000 patients a year to manage in the current system. So asking them to manage the rehabilitation of all our COVID patients is unlikely, I think, to be successful. Cardiac rehabilitation is similarly stretched. 135,000 people eligible for cardiac rehabilitation, about 38% of them get, and that's before COVID. And in my own particular area, in specialised commissioned rehabilitation services through NHS England, and this is data from 2015 essentially, there are 65 services in England, the whole of England. The there's about 994 beds available. Each of those can admit about 5 patients a year. So therefore you can see about just under 5,000 cases a year for rehabilitation, of which about 1,000 are available for trauma. Put that in context, when I was in the armed forces, we had 1,000 patients through a year in our facility alone, just for trauma. So there isn't much out there. And not only is it short in capacity, the capabilities for managing these particular complex cases aren't available. The other point I'd like to make is around what a case looks like. And these are just patients that I've seen in the last few weeks. They're very varied in presentation. What I found is...
You have 2 minutes.
Okay. What I found is that the importance of diagnosis in this. Not all the patients fall into nice, simple categories. They all have multi-specialty requirements. And let me reiterate the importance of having a diagnosis. So, for example, a 40-year-old with widespread arthralgia, 3 months after infection. I'm a rheumatologist. When do I start treating that as an arthritis? 37-year-old with significant cognitive impairment and occupational impact 9 months after a confirmed infection. How do we intervene in that? Simple things like COVID toe associated with synovitis I've never seen before. It's impacting on people's physical well-being and activity. A 38-year-old with profound fatigue, shortness of breath, chest pain, and a preceding history of health anxiety. A 37-year-old with fever, fatigue, chest pain, all of this 12 months after the infection, who I then discover has a spinal and peripheral joint arthritis. I don't know if it's been caused by COVID, I don't know if it's been en masse by COVID, but it's there as well. And finally, a 42-year-old, 12 months down the line, fever, fatigue, chest pain, and a recent onset of nausea, which caused us to investigate, and we found a liver metastasis from a colonic cancer. So these patients are not easy. The problems they present with are not simple. And I worry that we are not diagnosing with enough intensity. These people are not getting better. And I would say that clearly whatever model of rehabilitation we're providing, one size doesn't fit for all. Assessment clinics have a role, but they need to be resourced and they need to have an output and a direction of travel for the patients. What is the National Health Service's plan for rehabilitation? I heard only last week at a very high level meeting, we're discussing asking for further funding. Well, frankly, we've had a year to think about this. And this disease is not only a respiratory disease, a cardiac disease, a chronic fatigue condition. It's a variety and it's a mixture of all. And let me just say again, you've got to diagnose, otherwise you can't provide a functional rehabilitation program. Thank you.
Thank you very much. Our next speaker is Colette Ewan, who's going to be referring to physiotherapy perspectives in relation to long COVID. Thank you, John, and over to you, Colette.
Thank you very much, and thank you to Ewan for inviting me today. So I'm going to share my screen with you. Okay, so today I'm going to be talking about the perspectives on return to work with long COVID, in specifically regarding physiotherapy. So just a little bit about my background. I've had over 20 years experience of working in the NHS as a musculoskeletal specialist in acute and long-lasting conditions, but also as a manager providing service delivery, but also actually looking after staff and patients. So again, looking at return to work, but also working in education as well. I now work in private practice for Bespoke Wellbeing, who provide physiotherapy, occupational health, and ergonomics. So there's probably going to be some repetition, but that's never a bad thing, but maybe a slightly different perspective on some things as well. Okay, so we're going to be covering living with long COVID, the physiotherapy role, clinical and non-clinical challenges, how physiotherapy interventions may be able to assist those with long COVID, and return to work and physiotherapy. As we've heard, living with long COVID can be from a mild or severe initial infection. It can present with multiple symptoms which fluctuate over time and can be unpredictable. Recovery is unknown, and again, like many others here, I've seen people who have recovered really quickly after long COVID, and I've seen people who still have those symptoms. And what is really encouraging, and I think incredibly important, is the patients themselves. So those living with long COVID who are experts by experience. And I echo many who've mentioned, how we should be listening to those. I do have a history of working with those with, long-lasting conditions. And again, it's absolutely key that we do listen to our patients, and especially when we are providing services, but also actually supplying and doing those services as well. So as a manager and a clinician. We have lots of anecdotal evidence and real evidence that there is patchy access to care. And when people do have access, there are varied healthcare experiences. We also are aware that those living with long COVID can feel isolated and not heard, and frustrated and anxious because of that. So how can physiotherapy help? Physiotherapists help people who are affected by injury, illness or disability. We are able to utilise a variety of interventions, and we can help manage and prevent disease. Physiotherapists are good in encouraging development and facilitating recovery, and also in an occupational setting, but even not, just enabling people to stay in work. Physiotherapists are also experts in helping them remain independent for as long as possible. We work in a variety of specialisms in health and social care, neurological, neuromuscular, cardiovascular and respiratory being those core areas, but many more on top of that. And as we can see with the long COVID symptoms, which are hugely varied, physiotherapists do have an important role, as do other allied health professions, in helping to deal with this multi-system challenge. We are also rehabilitation specialists in whatever spectrum and definition you'd like to count that as. And as part of that, we're really good at assessing and managing our patients through a long period of time, collecting data and providing evidence. So this is an example of a referral pathway. Just some caveats with this. This is regarding online physiotherapy care, and it is through a private route. And my next slide will explain a little bit more about the challenges of providing a service. So a typical referral pathway, the employee has a persistent long COVID symptoms, so more than 4 weeks, more than 12 weeks, which is impacting their ability to work. The referral is made by a case manager or occupational health, and then the long COVID rehab program assessment starts. I should say, before they even go into the program assessment, they are screened here. And as we saw earlier, because of this multi-system symptoms that we're seeing, it's so important that we are just pre-screening, because this is because long COVID has so many spectrums to it, it's quite broad. It's really important that, what services we can provide are safe for patients. So the long COVID rehab program assessment, which in itself is quite long. And again, we have to be cautious that we are asking lots of questions. The assessment process in itself can be quite arduous. So again, we have to be really careful that, and again, listening to the patient, that we are not inadvertently making them worse, just with the assessment. From that, we can then establish what kind of assessment they're going to be having and what the outcome is. So it may be that the programme isn't required, there's a return to work plan which is sufficient and in place. It may be that they're not accepted onto the programme because they require further medical review, or it may be that they are accepted and then we can start a rehab programme. And with that, there are going to be a number of interventions, of which we can be talking more about later, covering fatigue management, breathing control, exercise rehabilitation, because we do have to recognise that there's going to be a number of presentations out there, but also supporting them in other ways, so sleep strategies and anxiety and depression strategies. Throughout this, they are reviewed each session, and obviously close contact with the case manager and with the service, so just making sure that they are ready for either further rehabilitation or discharge from the programme. I think the key message through here is that there is constant screening and re-evaluation going on, but also, as we're going to talk about later, it can be quite flexible, because again, we do have to recognise the fluctuating systems of somebody who living with long COVID. So let's talk about some non-clinical challenges, and again, these have been raised by some of the preceding speakers. There are issues with accessing services, and there's also issues with OCHALF referring on or even seeing an OCHALF specialist. So we do need to look at how we can make this as streamlined as possible. Attendance policies. So again, I have an experience in managing services within NHS, and there may be some things we need to look at regarding did not attend or even unable to attend. The appointments, the appointments themselves. Yep, appointments themselves. So again, looking at numbers and the flexibility of delivery. Again, I'm very conscious that some of our assessments can be quite arduous. So again, how flexible can we be? And also service delivery. We are able to do this in a number of ways, face-to-face, individual, online, or as a group. And again, acknowledging our staff specialisms and knowledge. Clinically, there is a diverse presentation. We have to ensure that what we provide is safe and based on what we know, best practice rehab. We also have deconditioned versus fatigue. And again, these have very different rehabilitation approaches. So again, how can we diagnose for post-exertional malaise and cardiac dysfunction and make sure that what we are provided is safe and relevant for that patient at that time? So very much a person-centered, risk stratified care. And also incredibly important, I think this is really interesting from the long COVID support groups, is again the importance of education and self-management. Again, physiotherapists and OTs are hugely specialised in helping patients develop those self-management techniques. And that's going to be a big part of these services. Return to work in physiotherapy. So it should be a coordinated approach between the employer and clinician. We have to have an understanding of the symptom fluctuation and also the vast differences in how we can actually manage these symptoms. Goal setting is imperative with an individualized approach, and functional restoration or acceptance, looking at task frequency, job physicality, cognitive tasks, shifts and hours, and as somebody mentioned earlier, the commute. Working from home is very different to working and travelling to a place. We are here to optimise function and independence in everyday activities, and again, promoting this self-management and peer support. So in summary, living with long COVID provides a series of challenges which may vary in symptom presentation and recovery. Physiotherapists are well placed to help and support, and services must be adaptable to the ever-changing long COVID symptoms. We need to recognise the differences in managing fatigue, deconditioning and musculoskeletal disorders, and before any form of exercise, screening is key. And really importantly, any return to work programme must be flexible to those living with long COVID to recognise relapses and new signs and symptoms which may present. Thank you.
Thank you. That was another interesting presentation, Colette. I think physiotherapy is key to recovery for many of our long COVID patients. And the final speaker for this section is Deborah Edwards. She's going to be talking about vocational rehab. So it's going to be bringing together what many of the speakers have already said and the importance again of early interventions. So over to you, Deborah.
Okay, thank you. I just want to make sure I get the correct screen showing. I'm hoping you can see the title page here, Work Relevant Symptomology. Everybody, yeah. Thank you for the opportunity to talk about vocational rehab and COVID. And it's already been such an informative afternoon, hearing the contributions from all of these esteemed colleagues, all of these people that have been engaged in trying to navigate this virus from the beginning to the real life details, from the real, the lived experience of these people that deliver rehabilitation, occupational services, and help people get back to work. So it's such an informative day, the international experience as well as government and NHS. I do want to thank Nick for, I think it was a scheduling mastery to put me at the end of all of this, because I think I'm going to change tack a little bit in talking about vocational rehabilitation. And I hope it'll round off, as Anne said, round off the afternoon with a slightly different slant before we go into the research elements. So I'd like to start with the big picture on health and well-being at work. And in 2019, all of the major health professional groups signed up to this consensus statement, which basically says that health and work are bound up inextricably to one another. And work gives us more than a paycheck. It can give us meaning and purpose to our life and contributes to both mental and physical health and well-being. As a representative of vocational rehabilitation, I want to say, perhaps a little bit controversially, that we need to reflect on what we've been doing and long been doing in the world of vocational rehabilitation, and that is addressing the obstacles that are preventing return to work. That's what we've done. Any process that enables people to overcome obstacles to accessing, maintaining, or returning to work or any other useful occupation. Basically, this means identifying barriers and finding solutions. And these barriers could be anything, not just workplace issues, as we've heard today from the lived experience and the symptoms that our long COVID colleagues are experiencing, that wax and wane throughout over many months and get better and come back to, and then get worse again. Supporting people with long COVID should not be vastly different from what we do with others who have developed long-term conditions, or in fact, those who have had serious injury as a result of an accident or some other of some description or not. The discussion throughout the media is politicizing rights of employees and rights of employers. But what we don't see being mentioned is that work is good for you. And of course, that is good work is good for you. I'm not surprised that we haven't been seeing much of this in respect in the media or in the discussion, because vocational rehabilitation has long been underrepresented, not just in the UK, but globally. And quite rightly, the focus for to where we are now, 1 year on, has been on reducing the instances of getting the virus firstly, and then surviving the virus. But now as we move on, we need to be, and hearing today even more so, promoting the message even stronger that there is support for people with long COVID. There might not be enough, and we've not got it right just yet, but there is support for people with long COVID to return to work, and that we shouldn't be afraid of having those discussions and those conversations, both from employers and with employees as well. So what I wanted to focus on in my next few slides is on workability. What people struggle with is symptoms, not pathology. Obviously, long COVID has pathology and in the thrust of the acute setting and even as we go through. But people move through these phases of recovery to the bottom line that keeps them from engaging not only in work, but in the other activities that they enjoyed pre-COVID, are those symptoms that are that they're experiencing at any given time. People with certain job demands may not notice certain symptoms at work, ergo these symptoms may not directly impact on their ability to complete those work tasks. And these symptoms are not work relevant symptoms. But people with another set of job demands may struggle with certain work tasks, but not other work tasks. And work relevant symptoms, results in the usual work being extremely difficult or impossible to carry out. And we know from what all of the comments within the chat and all of the people that we've heard today, these are very challenging times, and they need to be dealt with individually and focused in the right way. But work relevance is about this person in this job with these symptoms at this time. It is highly individual, and in speaking with our lived experience colleagues, these symptoms wax and wane, and they need to be dealt with during that process of waxing and waning. That doesn't mean return to work is impossible. So vocational rehabilitation, easy for me to say. So vocational rehabilitation is about identifying the characteristics of the symptoms, overlaying those on the task of the job, and ultimately changing the work to increase workability. And that, you could say, is like working while recovering. This workability research, and thus this house, was developed in response to workforce aging in many European countries back in the 80s, so it's not new stuff. And it is the result of a comprehensive concept of occupational health research developed by the Finnish Institute of Occupational Health. This workability house model, the floors of the house, as well as family and social networks, indicate dimensions that affect workability. Management and leadership skills on floor 4 have the strongest effect on workability. In the 3rd floor, the single factors that appreciation, trust, fair treatment, and support affect workplace well-being. A sustainable balance between these factors of work and human resources creates good workability. And workability is about having the health, the basic standard competence, and the relevant occupational virtues required for managing some kind of a job, and assuming that the work tasks are reasonable and that work environment is acceptable. Workability should be on the agenda for all stakeholders, for all employers, including unions and employees and all sorts of groups.
You have 2 minutes, Deborah.
Collective agreements are welcomed because those employers and employees are the winners. Better workability and workplace well-being leads to better productivity, which is the win-win situation. There's 3 reasons and problems that interfere with this success, and I could talk to you for a lot longer than my 2 minutes is going to allow. So I'm going to jump over that with just to say that, if you do a work survey, the list will be long that needs to be, of factors that negatively impact ability. So prioritization of those issues needs to be carried out. The second reason for less effective interventions could be low participation rates of people involved. So, and the third is about the employers and constructed so that health-related items are played an important part and role in scoring of this workability screening process. Without significant health effects being taken into consideration, the potential for improvement in the workability index is rather limited. So COVID definitely impacts on this. But on the other hand, improvements in management skills and work arrangements should be powerful enough to make some impact on this as well. And I think that we all understand that it is difficult for managerial skills, improved managerial skills, to significantly impact the knowledge that's transferred into practice. Let me see. So the principles are here. You'll see these on your own time. But what I really want to say is that the principles and concepts and deliverables are important. They're both important. We need to ensure that all players are on side, that high fidelity to these principles are crucial, and that trained, competent providers are coordinating between workplace health and society. And in fact, vocational rehabilitation is ideally placed to do that. I want to thank you for listening to me at this late hour of the day. And I want to thank Professor Kim Burton for his support in presenting this concept to you today. He really helped me out. Thanks so much.
Thank you. That was another fascinating presentation. I'm really pleased you mentioned Kim because Kim's book about work should be good for us is so important. So it's great that you've had his support, and he's done quite a lot with us at some. Okay, so thank you to Tony, John, Colette, and of course to you, Deborah. Another thought-provoking presentation. I could have listened to that for a lot longer than we actually gave you, so I apologise for being really strict and cutting you off in your prime. So, okay, we've been looking at perspectives on the challenges of developing an effective return to work for people with long COVID. So important. Our final session is a panel discussion, and we're very lucky to have Dame Clare Rayner and Professor Dame Carol Black to explore the research gaps and identify the next steps. Dame Clare Rayner is chairperson of the Council of the Royal College of General Practitioners from 2010 to 2013. She has got a professional interest in both mental health and substance misuse. Then, of course, we all know Professor Dame Carol Black. Dame Carol is, of course, one of our SOM patrons, author of Working for a Healthier Tomorrow, and past president of the Royal College of Physicians and of the Academy of Medical Royal Colleges. So over to you, Clare and Carol.
Well, and how did you want Clare and I to sort of talk to each other or with each other, or would you like us, one of us, to?
That sounds a good idea to me. Let me just check with Clare. Clare, are you happy with that?
I just missed what Carol just said.
I was thinking, Clare, that if we both said something to start with, we could.
Fabulous. So maybe a couple of minutes each, or a minute each. That sounds lovely, Carol. Lovely to see you anyway.
Good to see you. Okay,
we've been getting quite a few comments in the chat box, and I've asked Nick if he could collect them together, send them to me, and then I can pass them on to you.
If we start, and then if Nick has got some specifically research questions,
lovely,
that would be fantastic.
Shall I start, Carol?
You start, Claire.
Okay, well, thank you so much. What a fascinating afternoon. And I've not been able to stay for the whole lot because I've had other events, but I've listened to a fair whack of it. And it's been absolutely lovely. So first thing, me in context, I got COVID, probably one of the first doctors in this country to get COVID. So way back in early March last year. So everything that's been discussed here resonates with me and my experience of COVID in particular. The muscular aspects, the loss of ability to exercise, the desire to get back as soon as I possibly could to my own detriment. So everything is relevant. Where I come in terms of expertise, other than being, if you like, a patient, though I don't really associate myself with that, is I run a service for doctors and dentists with mental illness, now extended to all health staff in England. And I've run it since the beginning of the pandemic. Well, I've run it for 13 years, but from the beginning of the pandemic, we put on extra services and we've looked at what we've seen. Now, we saw from about May onwards, 100% increase in the number of doctors presenting to our service. So an enormous increase. And when we look at the symptoms they're coming mainly with anxiety, with fear, less so with trauma. And as part of that service, or part of the charity that I run called Doctors in Distress, we've also been running groups for doctors, and now we're running them over for nurses with self-identified long COVID. And we've run two groups, one's just coming to an end. The first one had about 70 people and the second one has 60. And we run groups, they're not therapy groups, but they're run on therapeutic lines. And we're just looking at the figures and the data, and it resonates exactly with what we've been seeing here. The most prevalent symptom is that of fatigue, and then going right down into issues such as muscle pain and brain fog. And of those that have been in the groups, the vast majority report improvement. So I'll leave it at that and hand you over to Carol.
Before Carol starts, somebody's got background noise. Could you just check if you're not speaking?
Sorry, it was me.
Was it you?
And
that's all right, Claire.
I didn't really. They're all next door. We now have, instead of doing it all on Zoom, believe it or not, I'm in real life in a real office with real colleagues next door, and it's extraordinarily lovely.
I'm sure it is. Okay, so over to Carol then. Your microphone's muted, Carol. Carol, you're on mute.
On mute.
Is that better?
That's perfect. Thank you.
Great. Well, like Claire, I just thought the afternoon was fascinating, and it's really showed us from a research point of view just how complex this is, and so many ideas have come up during the afternoon, and I think perhaps the first thing to say is long COVID may cover several conditions which have several causes, and And I think that's been pretty obvious during the afternoon. So how do we start to dissect some of those out? And I think the afternoon has shown us really, and it's not surprising that we've still got a lack of consistency around the definition and the measurement of long COVID. And therefore, if you're trying to put results together and looking at the different emerging results, that makes it difficult. But what has come through really pretty clearly this afternoon is perhaps that we have 4 type syndromes. Some people might want to argue it's 5 or more, but I just wanted to spend a minute or two thinking about those, because it reminds me about the disease I've specialized in for many, many years. I looked after patients with a very rare, uncommon disease called scleroderma. It was complex. We didn't know where to start. We didn't have anything to give patients who had this condition. And they had many organs involved. And that's exactly what we've heard this afternoon. But if you just think of the 4 syndromes or parts that seem to be emerging, of course they cross-relate and you can have more than one of them. But there's that long-term organ damage, which really interests me, because it seems to be as a result of the actual infection. I'll just highlight one bit of it, because I'll just take lung fibrosis. So as a result of having COVID, your long COVID could be dominated not just by being breathless, but maybe dominated by actual structural changes in your lung. And it seems to me that if that's one of your problems, then we need the researchers pretty quickly to start to use the same sort of drugs that benefit those people who have, for example, idiopathic pulmonary fibrosis. So start where you've got some diseases that look a bit like what you've got now, because one of the speakers said, and I totally agree, we can't wait 3 years to help patients. So can we find things that will shortcut it? So I would be keen, for example, to see research, clinical research done that uses information we already have and then tries it out in these different syndromes. I mean, pulmonary hypertension would be another factor. And then we have the whole part of the syndrome, which is, if you like, related to post-viral fatigue. There you need a much more holistic response, because you can't sort of go in with targeted therapy. And that's when I think you really must take this way beyond any medical research. So that's a very different sort of research, but we know people have tried things before. So I think one of the things I'm really saying is learn as much as you can from things which look a bit like these bits of COVID. And then, of course, really interesting to me is the inflammatory response, which might be ongoing, because it seems to be an inflammatory response against your blood vessels. And that resembles the disease I studied for so many years. And you have damage to the blood vessel, and therefore you may get clots, etc. Children tend to get chilblains. I'm sure you're probably aware that quite a lot of kids who get COVID suffer quite miserable chilblains. Again, use some of the drugs that we already have in our armamentarium. So I think I would start us off there. I mean, I'm sure there are lots of questions, and I could say a lot more, but it seems to me that we could start at a research level with the syndromes we've got, and saying, if we want to help people quickly at a research level, what are some of the things we could do now to start to learn more about what seem to be those different sorts? Although, let me say again, you can certainly have more than one of those, and most likely will. So, and is it worth seeing whether there are any questions in the chat box that Claire and I could address, or we can go on and talk more?
Absolutely. I mean, I didn't touch on the research questions because I was just introducing myself. But yes, I mean, I think what this summit has thrown up is how complex this disorder is, and how, if you like, some of the research questions have to start with how do the symptoms that people who have a label of long COVID, how similar or dissimilar are they to the general population? And because of course we know that symptoms of distress, pain is not uncommon in the general population. So I think we do many excellent studies have looked at the epidemiology, but I'm interested in what it is in terms of in comparison to the background levels. And I say this from the work, not necessarily about long COVID, but about doctors and mental illness and staff and mental illness related to this pandemic. Unless we look at it in terms of the background, what it was before COVID, the figures are, if you like, meaningless. And I also think, and I know it's been mentioned in this summit, the evidence or not around activity versus rest. And I think very soon that has to be teased out, not least because both not done in moderation can be harmful. So exercise exercise as I did early on set me back, but so too could be excess inactivity. So I think those are also the important research questions that need to be put out into the forefront.
Can I just pick up a question that's come in here? There's been a question asked about whether long COVID will fall under medical aspects of the Equality Act. Well, I'll address that. Basically, it's not a medical decision, it's a legal decision. But if it has a significant effect on the quality of life and ability to carry out activities of daily living over a 12-month period, or it could be expected to be over a 12-month period, then it is likely to be covered by the Equality Act. There was another question, and I've lost it now, but it related to how much research has been done in relation to COVID and mental health. So could either of you answer that?
Was there any more to that question, Anne? Because
I've lost it. I'll look for it.
A lot of, I mean, our work, which is clearly a small cohort, but I know Caroline Graham has been following a cohort through. So our cohort is that we know that having a long-term illness precipitates or can either precipitate or perpetuate a mental illness. So the overlap between mental illness and long COVID is significant, either as something that is a contributing factor. Also, if you're ill for a long period of time, we know that from my work normally as a GP, that any long-term chronic disease will interact and will give you a risk of mental illness. But in terms of whether, I don't quite know what the question is, whether there is a sort of more of an overlap, I don't know, but clearly time will tell. What is important is that we treat any underlying mental health problem, either if it's a causative or as it's a contributor later on, because we know that that mental health added to any long-term disease worsens the prognosis. So I think it is very, very important that we address that and treat that independently, whatever the other symptoms are. And that would go the same for anybody with a stroke, with cancer, with Parkinson's. We always have to be mindful of the comorbid mental health problems that may be there as well.
And there's two interesting comments which relate to the vascular problems. One, if someone said, I think it's Clare Rayner, if a vasculitic process is there, is it not imperative to address it and treat it urgently? I do think that, and I think we were perhaps more used to seeing it in the acute phase, and so as people learnt about the disease, they became aware particularly of that vasculitic component, really damaging blood vessels and causing all kinds of vascular events. And one of the ones, as I said, that really interested me was pulmonary hypertension, because you could trial sildenafil, prostacyclin. I mean, there are lots of things, within our armamentarium around vasculitis that you might be able to use. And then a comment about immunity and inflammation. And I think this interesting thing is how much does that inflammation either go on or recur. And I think there's so many things about this sort of seeming relapsing and recurring that we don't know. And is that part of an ongoing inflammatory process? And I suppose it's only by really recording, if we can, the patterns and the symptoms, and therefore what is happening to individual people, that we might start to get real clusters that then perhaps start to give us groups to work on and patterns of this condition. So I think we're in the foothills.
We are.
That shouldn't stop us trying to deal with, if you like, with the symptoms. Because if we're trying to wait until we understand it all, we're not going to be helping people.
Undine commented about the very interesting parallels with scleroderma and is wondering whether there's been any research highlighting this.
I could only sort of say, I know from what was happening at the Royal Free that we discussed whether some of the drugs that we borrowed, quite frankly and unashamedly, from other parts of medicine to support patients with scleroderma, could they be used in some aspects of COVID? And I know that one or two very small investigations went on there, but I think more internationally people have been really interested in if you like, vascular modulatory drugs. But there's some remarkable comparisons and the chronic fatigue, of course, is true to so many chronic conditions, and it's such a feature of COVID. I note in the comments there's quite a few questions and comments which pleased me very much about thinking about the workplace, and I think that is a really rich source of research, because it is surely going to affect people's ability.
But I think as Carol, as you said, we're in the early foothills, and I think we still do need to understand more. We need to understand prevalence. We need to understand the sort of incidence as well of symptomatology. We need to be ironing out. You know, even today we've heard the difference between people with catastrophic multi-organ failure versus, which is what I suspect Carol's talking about with the scleroderma, the vasculitis, right through to others who haven't had a positive test and may have, there are other issues that may be going on with their long COVID symptomatology. So I think this summit has been unbelievably helpful in taking a stock take of what is going on today and what needs to be done. I'm also interested in whether it targets different people in different ways. I mean, I know, for example, with the doctors in my group, for doctors, it's sometimes the very first time ever in their life they've been unwell, and the impact of being unwell is really quite significant, because my experience, doctors don't like to put their hand up and express their vulnerability. So they do go on far, far longer, if you like, in the acute sickness part when they maybe should have been resting. So you've also got different cohorts responding to the illness or the acute infection in different ways. But I think time will tell. And what we have got is, I don't know how many millions of people have had COVID now across the world, but we've going to have millions and millions of people in which to draw our data from.
Okay, well, there's been some very interesting discussions, a few questions in the chat box that I can't keep up with because they've disappeared, because so many people are putting comments in, they disappear. And I do need to draw it to a close now because we have slightly run over. But I'd just like to thank everybody, a huge thank you to all our speakers and panelists for joining us this afternoon and sharing your really such valuable insights. I'd also like to thank Ewan and Nick for your contribution to making this event possible, and to all our delegates from across the globe for joining us today. Lots and lots of resources are available on the SUM website. COVID-19 has been a very steep learning curve, and it will continue to present challenges in relation to both healthcare and employment and employability for some time to come. Your presentations this afternoon, I'm hoping, will help to shape those strategies that will support these facets. And certainly I do hope that we can come into the fore as occupational health professionals in relation to what we can do to support people to either remain in work or to come back to work. And I do hope that Alex Norris uses this presentation and this afternoon to ask some difficult questions in Parliament. So without more ado, I'll call this presentation closed. So thank you very much. A final comment from people here saying it's been a really thought-provoking event, really interesting, and to thank all the speakers. So there we go. Thank you. Bye-bye, everybody.